Good evening, ladies and gentlemen.
Sir, wait, sir. Wait.
Okay.
I will tell. Arvind, are you ready?
Yes, start, sir.
Start, sir.
Good evening, ladies and gentlemen. Welcome to the second webinar on acute pancreatitis. This is being organized by Indian Pancreas Club, and the organizing secretary is Dr. Sudipta Dar Chaudhary from CMC Vellore. As you know that for the first webinar was a grand success, and we are happy to continue with the second series. And I request Dr. Sudipta Dar Chaudhary to kindly take over and introduce the chairperson.
Thank you, sir. And it's my pleasure to welcome Professor Vivek Saraswat, a very notable gastroenterologist and a senior gastroenterologist of our country, who will be chairing the session, the first half of the session, which will be on the medical and percutaneous and endoscopic part of management of the second week onwards of acute pancreatitis. For the second half of this sessions, we have the surgical interventions in the acute pancreatitis, and we'll have Professor Piyush Sahani who will be chairing the sessions. Over to Professor Vivek Saraswat. Thank you so much, sir.
Thank you, Sudipta. Good evening, ladies and gentlemen. It's indeed a great pleasure to be here on this session under the aegis of the Indian Pancreas Club. As the COVID pandemic has progressed, we are moving through the full range of academic gastroenterology, from the beginnings, the basics, to now specialty and super specialty areas of highly specialized interventions and procedures. And acute pancreatitis is, as you know, an epidemic situation in our country. For the last several years, the numbers of acute pancreatitis have been going up, and most leading centers are regularly exposed to a large number of these patients. As we have gone along, our approach to this condition has gradually improved and stabilized. And I think this series of webinars will help put in focus where exactly we stand and how exactly we should be approaching this in a common and a coordinated manner. With these, I think the first talk in this session will be given by Dr. Pirama Nayagam, who is a consultant in the Department of Medical Gastroenterology at the Apollo Hospitals, Chennai. Pirama is one of our very good alumni and I'm proud to say that he is trained at SGPGI Lucknow, and he's always been a very quiet but a very sharp gastroenterologist who's very dedicated and sincere from his residency days at SGPGI. And he will be talking to us about the conservative management in the next 10 minutes. With these few words, I request Pirama Nayagam to please take over and take us through his part of the presentation. Pirama?
Sure. Good evening, sir. Thank you. Good evening to all. And thank you, sir, for your very kind words. It has been an honor for me to be presenting this again in front of you, in front of my mentor as well. And I thank Indian Pancreas Club for giving me this opportunity as well. Sudipta, can I have the slides, please? So my talk has been mainly about the conservative management or the supportive management of acute pancreatitis after the second week. So the first 2 weeks, the first has been dealt with in the first session. I think about that is mainly about it's mainly about supportive management, the ICU, and very close monitoring, and fluid resuscitation, pain relief, and starting off of nutrition. But this third to fourth week is the time where there is a gentle overlap between being completely supportive management and where we have to decide as to when to go on and intervene. And this is a very, let us say, a very variable period of time when patients present in a different way. So moving on to the slides, please. Sita. Sudipta, can I have the slides, please?
Yeah, I think he's probably working at it. He'll get it in a short while.
Sure. So going on, I think the outline of my presentation will be about the initial course, like what the revised Atlanta classification tells you about the terminologies about the fluid collections, because that has come up in the last 10 years where they have decided on what to call these collections. And we look at the local complications and how we deal with it in the third or fourth week. We have enough literature now to say how to manage once the local complication in the form of these collections get organized into a walled off necrosis. But in the intervening period from the third to fourth week where it is not yet walled off, what do we do? I think that's what we are trying to understand from these things. So in the first early phase of a pancreatitis is usually is usually characterized by a lot of pro-inflammatory state, and it's managed based on the systemic inflammatory response or the organ failure. And the severity is often assessed by functional or a clinical severity scoring systems. But moving on beyond 2 weeks, I think it moves on more towards assessing the local complications of acute pancreatitis. We have to look at the morphological aspects of local complications, and the severity is assessed more by imaging and as well as by definitely by the clinical criteria. So
do you not have the slideshow?
yeah,
I think Sudipta was presenting, and I think he had some instability with his connection. Maybe his connectivity is posing a problem.
If you have, you can share your slides. Okay.
There you go.
There you are. Okay.
There we are. Thank you. So the outcomes, because it's a mild pancreatitis with very interstitial pancreatitis, usually the outcomes are very good. The mortality is less than 1%. But on the other hand, about 10% of pancreatitis in the community tend to be severe or necrotizing pancreatitis, who develop organ failure during the first few weeks, and they sometimes resolve. It may be a transient organ failure. But over the next few weeks, the local complications in the form of necrotic collections take over. And if they are sterile necrosis, generally they do well and the mortality is less than 5%. But up to 40% of them do get into an infected necrosis, in which case the mortality jumps to about 15 to 25%. So, next slide, please. So in mortality of the acute pancreatitis, if you look at it, in this series about 1,000 patients with acute pancreatitis, you find of the 400 patients with severe acute pancreatitis, death occurred in up to 13% of people. And the first 2 weeks, we had about 50% of the death, in which it was mainly because of multi-organ failure, mainly secondary to the systemic inflammatory response and death. But when it happens in the late phase, that is after the second or fourth week, we find that most common causes an infected necrosis with following multi-organ failure. Next slide. So the local complications, as I said, the Atlanta has classified and has given us specific terminologies to be used. Next slide, please. So it turns it into 4 different categories. One is the acute peripancreatic collection, in which there is some fluid collection where there is no well-defined wall. It's a very ill-defined collection, but very clear fluid. There are no solid components to it. But after the end of the 4th week, or once it forms a good wall, we call it as a pseudocyst. On the other hand, towards the right, what we see is this inhomogeneous, a heterogeneous collection where you have solid and a liquid component without a well-defined wall. Is called as an acute necrotic collection. And as it matures, as it develops a wall, and usually it's arbitrarily defined as about 4 weeks. When it gets into a good wall, it's called as a walled off necrosis. Next slide, please. That gives you a pictorial representation of what we have just discussed. One on the left is the acute peripancreatic fluid collection without a well-defined wall. This usually happens in the setting of interstitial pancreatitis. With more than 4 weeks, it goes on to become a well-defined wall with a clear fluid. CT may not be the best imaging. I think we have more talks on it and how to assess this. So once you get a very clear defined wall with a clear fluid inside, it's called as a pseudocyst. On the other hand, on the right side, you find an acute, very inhomogeneous solid and liquid component collections around the pancreas. Without a well-defined wall, it's called as an acute necrotic collection. And beyond 4 weeks, once it gets a good, well-defined wall, it's called as a walled-off pancreatic necrosis. And the management for these also differ. So move on to the next slide, please. So we need to understand what happens to the natural history of this pancreatic fluid collection. In a series from PGI Chandigarh, we find that of the 189 patients who had admitted to the institute with acute pancreatitis, being a referral institute, we find that majority of them had a necrotizing pancreatitis, where far minority had an interstitial edematous pancreatitis. Of them, about the interstitial edematous pancreatitis, we find that only about 20% developed a peripancreatic fluid collection, and of them, only about 1% of them had went on to develop a pseudocyst. On the other hand, of the necrotizing pancreatitis, we find that about 80% developed an acute necrotic collection. And what is important to note is that about 1/5, that is 23 out of the 140 patients, expired within the first 4 weeks, even before they developed a walled off necrosis. So a portion of patients who have necrotic collections may die even before they develop a walled off necrosis for us to intervene. This may be because of their organ failure, which happens in the first 2 weeks, or maybe because of the persistent necrosis with an infection which sets in a little later. As it matures off, we find that about 60% of them develop walled off necrosis, and another 15% actually go on to resolve on their own with only supportive management. And I think that is the part that I've been asked to talk about. Move on to the next slide, please. We also would like to understand what happens to the walled off necrosis once beyond 4 weeks when it comes up. So about, again, 1/4 of them do well with only conservative management without the need for any interventions. So these may be predominantly sterile necrosis which don't get infected, in which case conservative management may be good enough. But for about the rest, about 60 out of the 80, that is about 3/4 of the people, they will go on to require some intervention or another. Going to the next slide, please. So supportive management in a patient, again, it depends whether the necrosis is sterile or it is getting infected. If it is a sterile necrosis, we just wait and watch. Main thing would be to take care of the nutrition. Most often the nutrition started off in the first early weeks of the pancreatitis, and hopefully they go on to take an oral diet by the time they get discharged. But sometimes even patients with sterile necrosis develop large collections, and which may interfere with their feeding, and they may come back with poor intake, in which time there is a role for starting off enteral nutrition support, either by nasogastric or by nasojejunal tube feeding. If they are infected, we have to go on to give antibiotics. Moving on to the next slide, please. Can we skip this slide? The next, please. So oral feeding to be started early in mild acute pancreatitis, and enteral feeding should be the preferred mode of nutrition to meet the nutritional demands in patients with predicted severe acute pancreatitis. Enteral feeding has been shown to decrease the risk of infectious complications, and that has also been shown that they decrease the risk of the sterile necrosis getting infected. And feeding can be through either nasogastric or nasojejunal. And polymeric formulations, which are cheaper, have been shown to be as equally effective as the more costlier semi-elemental or elemental diet nutritions. Next slide, please. So how do we manage the infected necrotic collections? Is there a role for antibiotics, antifungals? The current AGA guidelines do show that when infected necrosis is suspected, broad spectrum IV antibiotics with the ability to penetrate the pancreatic necrosis, preferably some carbapenems or quinolones and metronidazole, is to be instituted. Routine use of antifungal agents is not necessary. Earlier, there was some debate about the role of image-guided FNA from this necrotic collections to prove necrosis. But of late, I think most of the centers do not routinely perform image-guided aspiration from the necrosis, because quite often they may be negative, and there is also a risk of introducing infection into a sterile necrosis. So I think most centers do not do it as a routine, but I leave it for the deliberations later in the part of the talk. Next, please. So apart from this, the other common problem that we see is sometimes on imaging, we do find the splenic or portal and the mesenteric vein thrombosis. So do they require routine anticoagulations in the setting of acute pancreatitis? There have been multiple studies, and this is just a cohort where they compared the outcome of people who have got anticoagulated compared to those who did not. And they found that there is no difference in the mortality or the varices or the recanalization rates with anticoagulation. So right now, we don't have enough evidence to start oral anticoagulation unless they have something like a pulmonary embolism or bowel ischemia. A routine anticoagulation is not warranted when we do a supportive treatment in these patients. Next slide, please. So when do we say that enough of conservative treatment? When do we refer for an intervention? Whenever there's a clinical suspicion or a documented infection in this necrosis, and who do not who are not improving well, or who clinically deteriorate as we give continuing the supportive management, maybe in the form of spiking fevers or new onset organ failure, which will dictate us to think whether we need to intervene. And in the absence of a documented pancreatitis, an ongoing organ failure for several weeks is also considered as a relative indication for intervention. In the setting of sterile necrotizing pancreatitis, if it causes any luminal obstruction in the form of gastric outlet or a biliary obstruction, or persistent symptoms in the form of pain or persistent unwellness, and the setting of a disconnected pancreatic duct, there may be relative softer indications for intervention. The next slide, please. So why is there the consensus that we have to wait for these necrosis to wall off, and why do we continue the conservative supportive treatment for 4 weeks? So where did this start off from? Next slide, please. These start off from the era of open pancreatic necrosectomy, where they uniformly found that the outcomes with debridement of necrosis was far worse when they did it early. The one on the left shows that about 50% mortality when they did a pancreatic necrosis early on within the first 2 weeks, that has dropped down to 20% when they did it late. And on the right, you do find that as the days progress, like if compared to early intervention within the first 2 weeks, as compared to the last column where you have intervention later, you find that the mortality is much lower when we do debridement much later, that is more than 4 weeks. So that is the premise from which we start, or where we understood that we need to be more conservative, we need to delay the interventions. So that's what the AGA guidelines also say, that debridement should be avoided early in the acute phase and should be optimally delayed for 4 weeks and performed earlier only when there is an organized collection or a strong indication. But generally, we need to wait at least for about 4 weeks. Next, please. But there are some instances where people do not do well. As I told, even in the setting of a necrotic collection, they develop organ failure or spiking fevers. And when you are worried about sepsis, then we need to do some intervention. Nowadays, we have already enough literature to support what we need to do once it is walled off. There are step-up approaches is much better than open necrosectomy. It can be a radiological surgical step-up, or endoscopic step-up. So the surgical step-up approach starts off with a percutaneous drainage. And I think there is some evidence to say that we can drain if the patient is not doing well, even less than 4 weeks. At least start off with a percutaneous drain, tide over the sepsis, allow for the wall to form before we do a debridement procedure. So the first step of this step-up approach, that the drainage procedure may be done if the patient is not doing well in the acute, in the 3rd to 4th week also. Going to the next slide, please. So percutaneous drainage should be considered in patients with symptomatic collections in the early acute period without the presence of walled off collection and they are failing conservative medical management. This is the AGA's recommendation come up last month. Next slide, please. So when do we do that enough randomized control trial? We are still awaiting the results from the Pointer trial, which looks at early intervention, that is within 24 hours of someone getting detected with drainable necrotic collection, versus the routine delayed intervention for drainage more than about waiting for the necrosis to wall off. So I think this randomized control trial will throw more light as to whether we really need to just be supporting them till 4 weeks, or we start doing earlier interventions. Next slide, please. To summarize, most of the interstitial pancreatitis resolve without local complications. Supportive treatment in the form of nutritional support should be good enough. Majority of the necrotizing pancreatitis do develop local complications. We have looked at the terminologies that is to be used, and we also looked at the natural history of what happens to these collections as we over the next few weeks. The current treatment concept for these local complications of collections is to delay the intervention till the fluid collections wall off. That may take about 4 weeks. It is arbitrary. Supportive treatment buys time and optimizes patient for intervention later on. Nutrition is more important. Antibiotics if they are infected. About 15% of the patients with necrotizing pancreatitis may die as they wait for these necrosis to wall off in the form of due to persistent organ failure. And 15% may actually resolve with supportive treatment or with minimal interventions. Percutaneous drainage if clinical deterioration occurs, but we generally avoid debridement during the first 4 weeks. And the optimal draining of these timing of these drainage procedures still awaits results of this randomized control trial. And I thank you all for your time.
Well, thank you, Dr. Piramanayagam, for a succinct presentation on the conservative management of severe acute, supportive management of severe acute pancreatitis. I think that a couple of questions have come in, and maybe we can take the questions now before we move to the next talk in the series. And
Sure.
Dr. Prakhar from Ghaziabad wants to know, is a pleural effusion called a local or a systemic complication, or is it a part of the whole pancreatitis complex?
I think pleural effusion can start off even in the earlier phase, like in acute pancreatitis. At the presentation, they may have left pleural effusion. So I think it's very difficult to say that to compartmentalize as saying that it's a systemic complication. Of course, it's not that way directly local, but it is due to a possible leakage of pancreatic juice from the pancreatic, one of the side branches of the pancreatic duct, which then drains up into the left pleural cavity. So in that way, it is a local complication, but you do get to see that very early also.
Right. So reactive pleural effusions in the very early phase may not necessarily be a complication, while maybe reflection of severity, while if a pancreatic or pleural fistula is documented, that would definitely be a complication.
Sure.
Right. Dr. Ashok from Rishikesh wanted to know how to differentiate infected from sterile necrosis, apart from FNA and gas on CT, both of which are very difficult, not commonly found observations.
Right. The Dutch pancreatitis group is clearly shown in their data that in the first 2 weeks, it's very difficult to make out whether it is an infected necrosis or it is because of the systemic inflammatory response syndrome. So at least in that study or in their group, what they do is to go and sample this necrosis only in the first 2 weeks. Beyond 2 weeks, what they feel is that the clinical criteria where we look at new onset organ dysfunction or a persisting or a new onset fever, they find it is 90% sensitive in identifying an infected necrosis. And we don't really have to go in and sample this beyond the first 2 weeks of pancreatitis. The first 2 weeks is where the difficulty is in identifying whether it is sterile, whether it is because of a systemic inflammatory response in a sterile necrosis or it is an infected necrosis. But the clinical criteria should be good.
Let me come in here. I think
yes,
even during the first 2 weeks, there is no reason to sample the pancreatic fluid or the necrotic tissue. Okay. First 2 weeks, generally, we don't suspect infected necrosis. It is in the second week onward that you start suspecting infected necrosis. And because intervention is not indicated, we generally manage conservatively only. From third week, fourth week onwards also, when you suspect it in patients who have got fever, raised counts and other things, right now the current consensus seems to be not to do FNA, but base your intervention on clinical criteria. I think we can move on to the next talk. That was a very nice talk.
Thank you.
Right. Okay, thanks, Pirama. So
thank you, sir.
The next talk in this is going to be about the role of radiodiagnosis in the assessment of severe pancreatitis. And to deliver this talk, I have great pleasure in welcoming Dr. Pankaj Gupta. Dr. Pankaj Gupta is an assistant professor in the Department of Radiodiagnosis at the PGI Chandigarh, who is interested in GI radiology and interventional radiology and has a very large number of publications, as you can see, and also has won the Kishore Tauri Gold Medal of the IRIA for the best paper in 2019. So, Dr. Pankaj, if you could please start with your presentation. We have Dr. Pankaj has started screen sharing. Okay.
Thank you, sir. Thank you, the organizing committee, for giving me this opportunity to present in this forum. I'll be talking on the imaging issues as they relate to the management in third and fourth week of illness. This late phase of acute pancreatitis is characterized by increasing necrosis, infection, and persistent multiple organ failure. And unlike the early phase of acute pancreatitis, where there is a poor correlation between imaging and status of the patient, imaging plays an important role in deciding the need of treatment as well as the type of treatment in the late phase of acute pancreatitis. The indications of delayed imaging are lack of clinical improvement or clinical deterioration despite optimized treatment, and whenever an invasive intervention is being planned. The goals of imaging are diagnosis and evaluation of evolution of necrotizing pancreatitis and its complications, and determine when to perform invasive interventions. And once the interventions are performed, to monitor the treatment response and treatment-related complications. This has already been discussed in detail by the previous speaker. I'll be showing the imaging examples. So as already been highlighted, the necrosis could be parenchymal alone, which occurs in around 5% of the cases. It could be entirely extrapancreatic necrosis, which occurs in 20% of the cases. And the most common type is a combined type of necrosis, which involves the pancreatic parenchyma and extends to the peripancreatic tissue. As has been highlighted by the previous speaker, the differentiation of the necrotic from non-necrotic collection based on imaging could be difficult in the first week, as in this example, patient with pancreatitis, where we have some peripancreatic fluid, which could be difficult to differentiate whether it is necrotic or non-necrotic. However, in the second week of illness, one can see that now the fluid appears to be clear. So it was acute peripancreatic fluid collection. And in the lower panel, one can see that there is presence of well-defined encapsulated collections in the peripancreatic location with clear fluid suggestive of pancreatic cirrhosis. In acute necrotic collection, one can see that the collection is not encapsulated, and there is presence of inhomogeneous contents within the collection, which could represent fat or sometimes hemorrhage or solid debris within the collection. Ball duct necrosis, on the other hand, comprises of a encapsulation, that is formation of a ball, which could be complete or incomplete depending upon the duration from the time of onset of the disease, and is characterized by presence of internal non-homogeneous contents. CT has pitfalls in differentiation of necrotic from non-necrotic collections, and in some cases ultrasound can help, particularly when the collections are superficial. However, in pancreatitis, when the collections are deep, particularly in the lesser sac, ultrasound may not be able to do this job. And also in patients who are obese, ultrasound may not be able to differentiate and characterize the collections. Endoscopic ultrasound is an excellent modality to demonstrate the presence of internal solid debris. MRI also serves an important role in identifying the presence of the internal contents by showing T2 hypointense contents within the collection, as well as hemorrhage can be excellently demonstrated on MRI by presence of T1 hyperintense areas. The natural history of the different fluid collections has already been discussed. So it is important that one could accurately diagnose acute peripancreatic fluid collection, as interventions are not required in these collections, which resolve in most of the patients. And on the other hand, in patients with acute necrotic collection, infection could occur in 20% of the cases. And this is a group which would actually require the interventions. It is also important to document the effect of the collections on the adjacent organs. In this example, one can see that the wall of necrosis is causing extra hepatic biliary obstruction. And in this particular example, one can see that there is a severe mass effect on the stomach causing symptoms of gastric outlet obstruction. The compression of adjacent organs is one of the indications of drainage of pancreatic collections, despite the absence of infection. It is also important to demonstrate the extent of extrapancreatic necrosis, as it has been shown in multiple studies to correlate with clinical outcomes. This was a study from our group where we demonstrated that the site of the collection as well as the volume of collection was associated with the different clinical outcomes. Previous study also showed that 100 ml of volume of extrapancreatic necrosis could predict severe acute pancreatitis. And in another study from our center, it was shown that extensive extrapancreatic necrosis, which was defined as the extrapancreatic necrosis extending to the paracolic gutters, had significantly higher frequency of pleural effusion, ascites, and multiple organ failure. Infected necrosis is one of the important complications of acute pancreatitis, which occurs in around 20% of the cases and is associated with a very high mortality. It typically occurs between 2 and 4 weeks. Unfortunately, on imaging, the only sign of infection is presence of air, which occurs in around 10 to 20% of cases. However, it is again not a finding that is seen only in infection, could also be seen in patients who have fistulization to the GI tract or following interventions. And the lack of infection in a collection doesn't exclude infection. The other gastrointestinal complications include the other local complications are the GI complications, which can be due to the enzymatic action or the effect of other local collections. So inflammatory thickening of the bowel is quite commonly seen finding in patients with extrapancreatic necrosis. However, in some cases, it could be severe and can lead to the severe narrowing of the lumen, causing obstruction. And it can also cause the necrosis and infarction of the bowel in some cases. The other gastrointestinal complication is the GI fistulization, which can lead to spontaneous resolution of collection in some cases. In other cases, it can lead to persistent infection within the collection. And sometimes the communication with the bowel could be iatrogenic, as in this case, where a catheter is placed in the left paracolic gutter collection and is seen within the lumen on colonoscopy. Bowel dilatation could occur as a result of paralytic ileus and could be one of the contributing features for intra-abdominal hypertension. The vascular complications of acute pancreatitis are classified into arterial and venous. Arterial complications are dreaded and have a very high mortality rate. Pseudoaneurysms are seen in 3 to 10% of cases and most commonly occur in the gastroduodenal and splenic areas. Splanchnic vein thrombosis is also common, which most commonly involves the splenic vein. And it usually is clinically silent, however, can lead to left-sided isolated portal hypertension in some patients. The evidence of hemorrhage could be in the form of hyperdense contents on non-contrast CT. And on arterial phase, one can depict the presence of aneurysm, as in this example, where the aneurysm is arising from the gastroduodenal artery. These are the examples of pseudoaneurysm arising from the left gastric artery, from the splenic artery. And in some cases, despite the clinical evidence of bleeding, only the hyperdense contents may be demonstrated. The presence of pseudoaneurysm may not be demonstrated on CT, in which case the digital subtraction angiography may be used for both diagnosis as well as for the management of the pseudoaneurysms. Disconnected pancreatic duct syndrome is a very common condition. However, it is underdiagnosed because of lack of understanding, particularly by the radiologists. It is characterized by complete disruption of pancreatic duct with isolation of viable upstream pancreatic parenchyma. The consequence of disconnected pancreatic duct is recurrent pancreatic fluid collection, new onset diabetes mellitus, and external pancreatic fistula in patients who have percutaneous catheters. And in a recent series from India, the incidence of disconnected pancreatic duct was as high as 73.8%. And in a previous series, the disconnected pancreatic duct syndrome was present in 46.3% of the patients and was more common in Waldorf necrosis. Diagnosis of disconnected pancreatic duct syndrome relies on the demonstration of necrotic pancreas, which involves 2 centimeters or more of the pancreatic parenchyma, usually the pancreatic neck or the proximal body, viable pancreatic tissue in the tail of pancreas, and pancreatic duct entering fluid collection at 90 degrees. If endoscopic retrograde pancreatography is performed, it demonstrates a cutoff of the pancreatic duct. CT can diagnose DPDS by 2 weeks. However, the delayed diagnosis has been documented in several series, and one of the reasons could be lack of understanding of this disease entity. In this example, one can see that there is complete disruption of pancreatic parenchyma in the region of pancreatic neck. And on thin sections, one can see that pancreatic duct is seen to enter into the collection. Another example where we can see there is a large complete necrosis of the pancreatic parenchyma in the region of proximal body, and on thin section CT, one can see that the pancreatic duct is entering at 90 degrees to the collection. ERCP shows complete disruption of the pancreatic duct in the region of pancreatic body. However, the pitfalls in diagnosis of EPDS must be understood, as large collections can cause extensive compression of the parenchyma. And in these situations, one has to look for a thin bridge of viable glandular tissue that will allow to correctly diagnose the absence of pancreatic duct disconnection. And also, imaging tests sometimes may not be able to differentiate peripancreatic necrosis from pancreatic parenchymal necrosis and pancreatic duct necrosis. So in these situations, MRCP may actually be helpful to depict the ductal anatomy. Imaging is also useful in evaluation prior to interventions, in which case the location of the collection, encapsulation, varices, solid debris, and pseudoaneurysm or traversing vessel must be carefully looked for. And in the post-intervention evaluation, the reduction in the size of collection, bleeding, perforation, secondary infection, migration, and buried stent syndromes should be carefully looked for. In this example, one sees that a lumen-opposing metal stent has been placed across the stomach into the peripancreatic collection, and despite that, the collection has not resolved, which means that there is need for further necrosectomy sessions or additional drainages. In this example, one can see that multiple plastic stents have been placed across the collection, and there are hyperdense contents on non-contrast CT. And in the lower section on arterial phase, one can see that there is active contrast extravasation from the left gastric artery, suggestive of bleeding complication. So take-home messages are that imaging is an integral part of management of acute pancreatitis in the late phase. CT is the mainstay of imaging. However, there is increasing role of MRI and EUS in the characterization of collections. Detection, characterization, and follow-up of collection is a critical goal of imaging. Bowel complications, vascular complications, BPDS should be carefully looked for on all imaging studies. And imaging also plays a very important role in pre and post-intervention evaluation. Thank you very much.
Well, thank you, Dr. Pankaj, for an excellent overview and a comprehensive coverage of the multiple facets that we encounter in people with severe acute pancreatitis. I think I'll just pause briefly for two quick questions before we move on to the next talk in the session. And one is that, is there a role for diffusion-weighted MRI for identifying infected pancreatic necrosis? Is what Dr. Nalinikant wants to know.
Sir, a few studies have been done, but it is not a routinely utilized imaging method, because as already been highlighted, actually the more important scenario is the clinical condition of the patient. And so we are moving more from the imaging aspect to the clinical scenario of the patient for diagnosis.
And do all pseudoaneurysms need to be intervened, or you would there any place for expectant management of pseudoaneurysms?
No, all pseudoaneurysms should be dealt with either through endovascular, surgical, or endoscopic ultrasound. Whatever route is feasible, all pseudoaneurysms must be treated.
Right. Thank you so much. So I think thank you for this excellent talk, Pankaj. We now move on to the, if you could stop sharing your slide, please. And we then move on to the next presentation in this session. And it's a great pleasure for me to call upon Dr. Shyam Kumar Keshav for talking to us about the role of percutaneous interventions. Can I have the slide, Sudipto?
Yes, sir.
Yes, thank you. Dr. Shyam Kumar Keshav is the Chief of the Department of Interventional Radiology at the Christian Medical College in Vellore. His area of interest is primarily interventional radiology, and he has a very large number, over 200 publications. He's also the editor of the Journal of Clinical and Interventional Radiology. With these few words, I request Dr. Shyam to please give us his presentation. Thank you.
Thank you, sir, for your kind introduction. I also thank Indian Pancreas Club for giving me this opportunity. Am I audible?
Yes, you are. Very
okay.
audible.
Okay.
The slides can
So in this short presentation, I'm going to tell when to do percutaneous interventions, why we have to do, and how to do. Some of these points have been already covered by the previous two speakers. I must emphasize that revised Atlanta classification has helped all of us so that we all can speak in the same language. So as you can see, as far as possible, we should wait till 4 weeks. And the indication for drainage includes if there is suspicion of infection or if it is causing some obstruction because of the space occupying problem, whether it is causing obstruction to the gastric outflow, etc. I'm going to show a few case examples. This is a 22-year-old male patient who presented with severe abdominal pain, 4 weeks duration, and he's having fever since 1 week. Since it is an academic session, I'm just showing on plain radiograph itself. You can see medially displaced stomach here, and you can see indentation on the greater curvature of the stomach. And what is classically described as colon cutoff sign. You can see the descending colon is stopped here on plain radiograph itself. This is the appearance on ultrasound abdomen of the pancreas, where you can see a hypoechogenic area in the region of pancreas. Now, in the CT scan, you can see there is collapse of left lower lobe. There is pleural effusion on the left side. And as I scroll these images, you can see that there is a collection posterior to the stomach. And it is involving the body of the pancreas. And as we can see lower down, it is extending up to the tail of the pancreas. So when we see this imaging, we particularly look for this short window between the descending colon and the spleen. So this is the area where we can enter relatively safe for percutaneous drainage. Since pancreas is a retroperitoneal structure, whenever we perform drainage, as far as possible, we try to remain extraperitoneal. Of course, other approaches are also described in the literature. Coming to choice of drainage tube, we have either pigtail or Malicot. It depends. People have used both of them, and there is good response from both. And the usual drainage tubes selected are in the range of 10 to 12 French diameter. Now, when we plan a percutaneous drainage, one good thing is patient is kept in supine position, or as in this case, we may slightly elevate the left side of the patient so that patient is comfortable in this position. Then we have planned a track between the descending colon and the left kidney. Then with the sterile techniques, we pass a needle inside into this hypodense area on the CT scan. In case if this gap is not adequate between the kidney and the descending colon, in another case, we have kept the patient in the right lateral position. You can see that this is the CT table. Patient is lying down on his right side so that the descending colon can fall slightly anteriorly so that there is increased gap. If this gap is not adequate, further we can instill some saline between these two so that artificially we increase the space so that there is a safe window to reach the pancreas. Then we place a tube and follow up the patient along. And so this basically helps along with the other types of management of pancreatic collection. Now you can see that 3 months later, this collection is totally completely gone. And you can see the tube which is placed earlier is between the colon and the kidney. Now, this patient is an uneventful type of clinical outcome, what we saw. Whereas whenever there is a need to improvise efficiency of drainage, several things we can do. We can put a larger tube, we can change the tube, or we can put a second tube parallel to the first tube. You can do saline installation and aspiration, and this can be even done between two tubes. And recently I saw a publication by Dr. Pankaj Gupta et al., where they have done an aggressive protocol where they kept on upsizing the catheter whenever there is inadequate drainage, and they have also drained all the new collections. And one more addition is augmentation, as we can discuss in the subsequent part of the talk, where we initially place a drain and later we upgrade. It can be either surgical or endoscopic. This is a very sick patient. As you can see in this imaging, there is large area of necrosis. You can see multiple air pockets here. So in this patient, you can see extension of this collection like amoebic pseudopodia downwards into the abdomen. So here we have planned for 2 steps: image-guided percutaneous drainage, see how he responds, and if it is not adequate, plan for a percutaneous necrosectomy. So this is a line diagram what I borrowed from the literature, which shows placement of the tube and subsequent drainage. So this is how necrosectomy was done in this particular patient. And this is a lot of necrotic collection, what was collected. And this is during follow-up, where we can see the drainage tube is still there and pancreas size has become small. So there are many publications, as you can see, but this is the landmark publication, which clearly said that when it is done as a step-up procedure versus open necrosectomy, there is obvious benefit to the patient. However, there is not much of mortality difference in this particular article. And new onset of multi-organ failure was about 1/3 in a step-up procedure. Similarly, new onset of diabetes was also 1/3. However, these results were better in a German study where they found almost 3 times betterment in case of step-up procedure in various aspects, and that included mortality and onset of diabetes. So their recommendation was step-up approach is better than direct surgical approach. Now, let me move on to another case. This is a patient who presented with abdominal pain radiating to back. Patient had hematemesis. Patient was known alcoholic. These are the CT images where we can see there is aggressively contrast filling area. This contrast density is almost similar to the contrast density what we see in the aorta and other arteries. And there is a huge thrombosed component of the pseudoaneurysm. In a pseudoaneurysm like this entire thrombosed and non-thrombosed portion is part of the pseudoaneurysm. Never underestimate a pseudoaneurysm by looking at only contrast filled area. That can be small. This kind of patients need to be treated immediately because if it bleeds, it can be fatal. So this is a large pseudoaneurysm, what we see from celiac angiogram. This was attempted to coil initially, but the coils slipped. And subsequently, what we have done is we placed a covered stent across this area. And after that, the bleeding was stopped. And he had some leakage still, which was managed by a percutaneous injection of the glue. And here you can see the pseudoaneurysm. With the help of ultrasound abdomen, we can see this entire pseudoaneurysm is thrombosed. So this is a follow-up where we can see that the whole pseudoaneurysm is blocked over a period of time. This is my last case in the short presentation. He's a young boy. He presented with hemoptysis. Please note that it's a hemoptysis, not hematemesis. He was a known case of pancreatitis. This is a chest radiograph where you can see blunting of costophrenic angle. This is a representative CT thorax where we see ground glass appearance of left lower lobe, not much of pleural effusion. And these are MR images where we can see there is collapsed lower lobe of the left lung. And as we trace lower down, we can see a thin tract going across the diaphragm, and it is leading to the pancreas, tail of pancreas. So in essence, this patient has got a pancreatico-transphrenic pleuropulmonary fistula, and bleeding is happening to the bronchial tree. This child was referred to us, can we do bronchial artery embolization? Instead of that, what we have done is we took the patient to CT room and we kept the patient in prone position. This is the track which is going between the pancreas and up to the airway. We identified on the CT scan. We passed a needle, and this needle tip was placed into this track. As soon as we placed it, we could get fluid from the tip from the hub of the needle. Through this, we injected glue. This is the glue cast, what we can see in this defect. And as soon as we place this glue inside this, and we followed up, and patient's hemoptysis stopped. So this is a rare example. Instead of pancreatic juice forming collection, it is directly draining into adjacent airway. So we have seen few case examples. Usage of universal terminologies in the last decade has really helped us, for all of us, to understand the management better. We emphasize on team approach. We follow standard guidelines. However, for a select case, there can be a tailored approach required if the presentation is unusual. Percutaneous drainage is safe, effective. And one advantage of percutaneous drainage is whatever is drained, it is visible outside. So that is one of the advantage what we see. And it also allows upgrading or step-up approach. So these are few points to share in my presentation. Thank you for your kind attention.
thank you very much, Dr. Shyam Kumar, for this very nice and elegant overview of percutaneous interventions in acute pancreatitis. As we know that beyond the second week is the time when most of the gastroenterologists will rush to intervention radiologists for all kinds of CT, MR, and interventions. And when they have patients with bleeding, that's the time they will rush and say, okay, do something, patients really deteriorating. So thank you very much for this insight into the percutaneous interventions, which has really become a very important component of managing these patients with acute severe pancreatitis. I mean, without intervention radiologists today, we really can't do much, not only in terms of diagnosis, but also in terms of definitive treatment in these patients. So thank you very much. So before we take up the questions, we have a session on question answer session. We can move to the next talk. And
Okay,
the next talk,
Thank you, sir.
please stay on for this session. We'll have
Yes, sir.
question answers. And we move on to the next talk that is on endoscopic interventions in patients with acute pancreatitis beyond the second week. And so some of the patients require early, some patients require late. So it's my pleasure to invite Dr. Pravir Rai, who is professor of gastroenterology at SGPGI Lucknow. And he is a very active endoscopist, has deep interest in pancreaticobiliary diseases, has published more than 50 articles in index journals, and is on editorial board of many journals such as World Journal of Gastroenterology, Endoscopy, EUS Journal, and a reviewer of many other journals. So pleasure inviting Dr. Pravir Rai for talking on the endoscopic interventions in acute pancreatitis. Pravir. Has Dr. Rai joined in?
Yeah, he has joined.
Yeah, okay. You could start sharing your screen and then.
Yeah, am I audible?
Yes, go ahead.
Okay. I would like to thank Indian Pancreas Club for providing me this opportunity. I'll be talking about endoscopic intervention in acute pancreatitis beyond second week. So it basically means we treat pancreatic pseudocyst, walled-off pancreatic necrosis, and vascular complication, predominantly pseudoaneurysm, which we do EUS guided. However, for the want of time, I will be discussing only pseudocyst and walled-off pancreatic necrosis. So this you have already seen. Before 4 weeks, what you have is acute pancreatic fluid collection, which evolves after 4 weeks to a pancreatic pseudocyst. While in the setting of a necrotizing pancreatitis, the collection for that forms of less than 4 weeks duration is an acute necrotic collection, which evolves after 4 weeks with a wall to walled-off pancreatic necrosis. So in pseudocyst, what one needs to know is that it develops in around 50% of all patients with acute pancreatitis. Out of these, 70 to 90% resolve, 10 to 30 form pseudocyst out of the acute pancreatic fluid collections. Pseudocyst also resolves spontaneously in around 70 to 85%. The rule of 6, which was more than 6 centimeters, more than 6 weeks in size, merited drainage is no more applicable now. We'll come to the indications. So the guidelines for intervention in pancreatic pseudocyst, it needs to be symptomatic, infected, or increasing in size, preferably after 4 weeks. The symptoms that we can have with pseudocyst are gastric duodenal outlet obstruction, extrahepatic biliary obstruction, significant and persistent pain, early satiety, vomiting, GI bleed, pancreatic ascites, and pleural effusion. So these are the indications for which drainage is indicated. So we have a variety of options. This is conservative endoscopic drainage, percutaneous drainage, and open or laparoscopic cystogastroscopy. What I'm going to discuss is predominantly endoscopic drainage for pancreatic pseudocyst, which can be a transmural or a transpapillary drainage. This is considered now to be the first line therapy for pancreatic pseudocyst. It has got significant advantage compared to surgery or percutaneous drainage. When a cyst is single, no ductal disruption, we have good success rate. We need to have a distance between the pseudocyst and the stomach, the duodenal wall, to around 1 to 1.5 centimeters to achieve a safe drainage. And cytopuncture is usually the site of the bulge in the GI wall. So now routinely all pseudocyst drainage should be done under EUS guidance. The reason is it has higher technical success and can be done in non-bulging pseudocyst. It avoids intervening blood vessels, lower complication rate, identifies debris within the pseudocyst, and in 5 to 90%, it changes management as it identifies cystic tumors, very important. So this is how a pseudocyst drainage is done. You can see bulge on the posterior wall of the stomach. This is a pseudocyst, and then you puncture initially with a 19 gauge FNA needle. So this is the pseudocyst. Now you can see the needle coming in here. Once the needle is in the pseudocyst, you remove the stylet, pass the wire, and then dilate the tract with a CRE balloon. And then you can choose to deploy either multiple plastic stents, which are usually placed in patients with pseudocyst, or as in this case, we are deploying a metal stent. So this is a 2 centimeter, 14 millimeter diameter metal stent being placed here. And if you get infected fluid from here or the pus draining out, as in this case, you can choose to place an endoscopic nasocystic drain to do irrigation later on. So sometimes transpapillary drainage is employed, and you have the fluid collection should be less than 5 centimeter. And if the PD stent which you place diverts pancreatic juice and allows the cyst to collapse and heal, bridging the PD leak is very, very important to ensure success. The size of the stent is the largest caliber which can fit in the pancreatic duct. However, the main risk is secondary cyst infection. So these are the studies, 2 studies importantly, which compare EUS versus conventional drainage. As you can see, the predominant difference that is shown in the study is only the technical success, the treatment success and the complication, though it is claimed that you achieve less adverse events with this, the studies show that they are equivalent. So EUS versus surgery for pancreatic pseudocyst, one is a case control study, another is a randomized trial. As you can see here, the length of hospital stay as well as the cost in both this case control and the randomized study was more in the surgical group. So endoscopic drainage has limitation. When you have a distant cyst, endoscopic expertise is not available, or patient with altered anatomy like Billroth 2 or gastric bypass, endoscopic drainage will be difficult. So coming to Waldorf pancreatic necrosis, indications for intervention in Waldorf pancreatic necrosis is proven infected pancreatic necrosis, clinically suspected infected pancreatic necrosis, that is ongoing organ failure for several weeks despite optimal medical therapy. Once you have symptoms of organ compression like outer obstruction, intestinal or biliary obstruction, and pain due to mass effect, or the abdominal compartment syndrome. So as you can see, the incidence varies from 1.8 to 40% in different series. Options again, you have conservative drainage, which can be percutaneous, endoscopic, necrosectomy, which can be video-assisted retroperitoneal dissection, or endoscopic necrosectomy, open or the laparoscopic necrosectomy. So we'll be talking about endoscopic drainage. You can either perform drainage with a plastic stent or a self-expanding metal stent or a lumen-opposing metal stent. Following this, you can do necrosectomy with or without metal stent. So endoscopic necrosectomy, a few words about the technique. At the index section, it is only performed if you have minimal of liquid which drains. It's usually done with a gastroscope. The technique involves 3 steps importantly: debridement, extraction of necrotic debris, and irrigation. So we need to understand all these 3 steps. Debridement, primarily you do with the polypectomy snares, or you use a braided wire snare if you have an adherent debris. Once you have done debridement, the debris needs to be extracted, and this can be done using gastroscope, rat tooth forceps, or the polypectomy snares. After this, you irrigate the cavity. This is done with a normal saline. And at the end of the procedure, you instill around 250 to 300 ml of hydrogen peroxide along with normal saline. Again, we don't have many studies to prove that this really works, but this is what usually practiced. Post necrosectomy, you end up placing 2 7 French 4 centimeter double pigtail stent and an ENCD to ensure irrigation. So this is how you can see this is the necrotic material, and with the rat tooth forceps, you can pull out this necrotic material. And this obviously is a procedure done with CO2 insufflation. And then you need to give time to this procedure. One sitting isn't enough when you have more significant debris, say more than 40 to 50%, you may need multiple sessions to complete the procedure. So this obviously needs patience, multiple settings, and done nicely, it's a rewarding procedure. So coming to the results of these, if you can see with pigtail stents, you have success, clinical success varying from 80 to 90%, technical success again 80 to 90%. Same is with metal stent, 80 to 100% success and 80 to 100% technical success. So plastic, metal stent, and in metal, the straight stent versus the dumbbell-shaped stents or the lumen opposing metal stents. So I have summarized this. Till date, we have these few meta-analyses. This again from 2015 to 2019. And if you see these meta-analysis closely, all comprising of significant number of studies and significant number of patients. So in this meta-analysis, two meta-analysis, it was predominantly WOPN. One showed it doesn't matter, there wasn't much difference between the plastic and the metal stent, while the other showed that the metal stent had an advantage as far as the clinical success is concerned and less of adverse events. While the studies, which included both the pancreatic cirrhosis and WOPN, two of them mentioned that it doesn't make any difference between plastic and metal, while the one suggested the metal stent had an advantage of clinical success and less of adverse events. So again, mixed results with this. So what does the AGA say? These guidelines, again published in June 2020 in Gastroenterology, suggest that self-expanding metal stents in the form of the lumen opposing metal stent appears to be superior to plastic stents for endoscopic transmural drainage of necrosis. So we keep on talking about step-up approach. So the step-up approach is primarily you do either an endoscopic or a percutaneous drainage with plastic stents and irrigation, followed, or you place a self-expanding metal stent or lumen opposing metal stent. If this doesn't work, patient remains symptomatic or develops sepsis, you resort to direct endoscopic necrosectomy. If this doesn't work, the patient doesn't respond, then you resort to debridement, which can be surgical, either minimal invasive, laparoscopic, or an open one. So this is what step-up approach is. So primarily what you're trying to do is delay, then you intend to drain, and then you intend to debride. So 3D becomes very important for necrotizing pancreatitis. So the points that you need to consider while performing intervention is clinical condition of the patient, local expertise available. When you have a solid or predominantly fluid contents, if you have a solid, video-assisted retroperitoneal debridement is the way to move. If you have liquid, you can do an endoscopic or percutaneous drainage. There are some definite trends now in treatment of necrotizing pancreatitis. Now we intend to delay things, aggressive to minimally invasive, single step to step up now, and percutaneous to endoscopic approach. The other point is the anatomical location of the necrotic material. If you have a central retrogastric collection, then you do either endoscopic transgastric or a laparoscopic transgastric approach. If you have a retrogastric collection with paracolic gutter extension, you need to do a PCD with step up to videoscopic retroperitoneal debridement, or you choose an endoscopic debridement with addition of a PCD as needed. If you have a retrogastric collection with extension to the right of the mesenteric vessels, you resort to an endoscopic approach, laparoscopic transgastric, or the patient may need open debridement. This is what the AGA guidelines now suggest. Few words about early drainage of pancreatic necrosis. So pancreatic debridement should be avoided in the first 2 weeks as it leads to increased morbidity and mortality. This is what the AGA says. It should primarily be done after 4 weeks, and it should be performed earlier only when there is an organized collection and a strong indication. Strong indication means the patient is deteriorating, developing sepsis, and you have a collection sitting there. Then obviously you intend to drain immediately after second week, that is in third or fourth week of pancreatitis. So this is a recent study, GI endoscopy again this year, 2020, which compares early intervention versus late intervention. Early intervention here meant between 15 to 27 days of the onset of pancreatitis. And if you see, the only thing that was different between the two groups was predominantly the days, length of hospital stay, number of ICU days. Besides this, there was no difference in the clinical, technical success or the adverse events. So what was concluded in this was that early endoscopic intervention of pancreatic necrosis in 3rd and 4th week appears safe and efficacious, provided there is a clinical indication for urgent intervention, and CT demonstrates a partial or complete collection wall. So you need to have a wall. In this particular study, they visualized the formation of the wall, which was either partial, that is around 20 to 80%, or complete formation of the wall. So this is what the approach to Waldorf pancreatic necrosis is that we discussed. So the algorithm primarily says that if you have an inflammatory, if you have a pancreatic collection, the drainage is indicated, the duration is less than 4 weeks, and it's an acute pancreatic fluid collection, you primarily resort to percutaneous drainage. Even if it is an acute necrotic collection, you resort to percutaneous drainage predominantly less than 4 weeks. If the patient doesn't improve, then you resort to video-assisted retroperitoneal debridement or transgastric surgical debridement. Here it improves, you are done with it. If it is more than 4 weeks and it is a pseudocyst, more than 5 centimeters, then more than 5 centimeters, you resort to EUS guided drainage, or you can do a transpapillary drainage as well if it is less than 5 centimeters. If it is a Waldorf pancreatic necrosis, you resort to an EUS guided drainage plus minus ERCP, or a percutaneous drainage can be done, followed by video-assisted retroperitoneal debridement or transgastric surgical debridement. So to summarize, only symptomatic pancreatic fluid collection need drainage. EUS guided drainage is the preferred modality for drainage. Before drainage, rule out cystic neoplasm and pseudoaneurysm in case of pseudocyst. Use of a single or multiple plastic stent suffices with high efficacy in pseudocyst. Fully covered self-expanding metal stent is more appropriate for Waldorf pancreatic necrosis. Endoscopic step-up approach is preferred for Waldorf pancreatic necrosis. Thank you.
Thank you very much, Prabir, for an excellent talk on endoscopic interventions in severe acute pancreatitis, particularly for patients who have got symptomatic fluid collections. So may I request all the speakers to come online and start their videos and audio. So there are many questions that we have received on the chat box, and we will take up some of these questions. So before I ask questions to the speakers, there are a couple of questions which are not related to today's talk, but I think it's important that we answer them. A couple of questions are on ulinistatin. What's the role of ulinistatin in acute pancreatitis? So in general, we don't have enough data to suggest that ulinistatin is effective in acute pancreatitis. I think it requires much more experience, and we need larger trials to recommend its use. Another question was about pleural fluid. Is it a marker for severity? So in general, it is taken as a local complication, but not really a marker for severity. One question was pleural fluid amylase. Is it high for diagnostic purposes? Generally speaking, it doesn't really matter much. The treatment depends on the amount of fusion that you have. If you're mild diffusion, you do nothing. If you're moderate or severe, you drain it. But if you have amylase, which is high in pleural fluid, then it suggests that there is leakage of the duct and it has gone into the pleural cavity. One question was the use of NSAIDs for pain. And we discussed in the last webinar that in general, opioids are better for analgesia in acute pancreatitis rather than NSAIDs. But if patient doesn't respond, you can give, there is no major problem with that. Now, one of the questions to the first speaker is that, is there a role for inflammatory markers in differentiating between sterile and infected necrosis? So Piraman, if you could take up that question.
So the inflammatory markers will go up in both. It's only an inflammatory state, so it doesn't differentiate infected necrosis from a sterile necrosis. It's only the clinical parameters.
People say in 3rd and 4th week might be helpful. In 1st week, procalcitonin is not very helpful, but I think beyond that, in 3rd and 4th week, procalcitonin is something that one can look at, might be helpful. So not really much. Okay. Another question is to Pankaj. Is CT required in every patient with severe acute pancreatitis?
Yes, sir. Answer would be yes.
So I think most patients who have got severe acute pancreatitis, if they survive the first 2 weeks, would end up having some local complications. Either they have a collection or a necrotic collection, they develop infected necrosis or large sterile necrosis. So most patients will require some CT at some stage. But my only suggestion is don't do a diagnostic CT just for the purpose of doing a CT. You should do a CT when you think a patient might require intervention. So or you suspect some complication. So I think a pre-planned CT in the second or third week is not something which is required. You do it when clinically indicated. Pankaj, would you agree with that?
So you mean to say that even in severe acute pancreatitis, we avoid doing a CT in the first week? I mean to say between 5 and 7 days to not look really at the presence of pancreatic necrosis.
So in general, if I have a patient who is suspected to have severe acute organ failure, even if I do a CT, it doesn't really help me because I know he has got severe pancreatitis, he has organ dysfunction. Knowing that he has necrosis either in the pancreas or peripancreatic doesn't help me in any way for the treatment part. It is only in the second and third week that I'm worried now that he has got some infection, he has got large collection, that I may need CT for intervention. So doing a CT at day 5, 6, 7 just to see necrosis doesn't help a patient.
I agree with you.
Okay. Another question for you is what is the best modality to find out solid contents in Waldorf necrosis in fluid collections?
So best modality would be ultrasonography. Either the transabdominal ultrasound is challenging, so EUS would probably be the best.
How about a T2 MR?
Yeah, T2 MR is more practical because it can be performed in most patients non-invasively, so it can be quite useful, though it may not tell us about infection that some of the question was asked, whether diffusion weighted imaging is useful.
So I think one of the indications for doing a T2 weighted MR is when you are planning to do endoscopic intervention, you're not sure I need to place a metal stent or a plastic stent. You want to know upfront. I think it's a good idea to do a T2 weighted MR if you are not happy with your transabdominal ultrasound. Although during the procedure, when you do EUS, you can find out the amount of debris, but I think knowing it upfront is also something that can be done. Another question is that this is to Dr. Shyam Kumar. When you do percutaneous drainage, do you start with a large size drain or do you start with smaller drain and then upsize it?
Usually start with about 10 French or 12 French, a small tube only we start, and if necessary, then we upgrade. This is what is conventionally followed throughout.
Right.
Thank you.
But one of the problems is that if you do drainage in patients with infected necrosis, those who have significant amount of debris, at 12 or 14 French really doesn't drain any necrotic debris. So either you have an aggressive plan, what you showed and Pankaj had published on that you keep on upgrading your catheters very frequently. One of the ideas that something that we are following is that right in the beginning, we place a 16 to 20 French catheter if the size of the collection is adequate and you get a good window. So Pankaj, would you like to add on that?
Yes, sir, absolutely. I agree with you. We should go for a larger drain size to begin with because that would avoid unnecessary delay and the worsening of the condition if infection is there.
Okay. Dr. Shyam Kumar, another question is there a classification for complications of percutaneous drainage?
No, I did not get the question, sir.
Any classification of complications of percutaneous drainage?
I am not aware of it, sir.
Okay.
I'm not aware.
Right. So, but you mentioned that the complications could be bleeding and bowel injury. So these are important complications.
Yes. I can name the complications, but I'm not, not aware of any classification.
Yeah, very true.
Thank you.
Right. Next question is to Praveer. You mentioned that hydrogen peroxide installation 250 ml. So question is that really needed? It could cause complications. Your thoughts on that?
Yeah, so I think we don't have any good study to prove or disprove that. So it is considered to be a sterilizing agent, but I don't think we have data to prove or disprove its role.
Right, but I want to put in a word of caution here. We used to use hydrogen peroxide for lavage of the cavity after necrosectomy, but we realized that it increases the pressure in the cavity. And in a couple of our patients, they developed peritonism after the procedure, which we attributed to use of H2O2, although we don't have a proof for that. So in general, we don't do lavage now with H2O2. If we do, we use small amount, and it should be diluted H2O2. So my suggestion would be, say, take 25 ml of saline, mix it, 50 ml, lavage it, and then lavage with saline. So I think one should be a little cautious in using this much amount of H2O2. This might be a little problematic.
And this is a half strength hydrogen.
Half strength, and which nowadays we generally avoid it. I think good drainage is the one which is really required. Pankaj, one of the questions for you is, what are the predictors of outcome of percutaneous drainage? Do you have any predictors to say this patient will respond to percutaneous therapy or not?
Sir, yeah, there are a few studies which have been published, and one of the predictors is obviously the size of the collection, and the other one is the presence of the solid contents within the collection. And in one of the papers, it was shown that if CT attenuation is more than 30 HU, that could actually suggest more solid component within the collection. So there are chances of failure of percutaneous treatment. And after treatment, the resolution of the size of collection within first 3 days, more than 50% has been shown as one of the outcome measures.
Okay. Piraman, one question for you. You mentioned that one should not drain early, we should drain late. So what are your thinking on early drainage in patients with severe acute pancreatitis in 3rd week or so, when they are showing signs of inflammation, continued sepsis, they're not improving, your CT shows a collection. So would you like to drain in the 2nd and 3rd week or not?
Yes, so that's what I mentioned to you. If the patient is persistently unwell or develops a new organ failure, we go ahead with the drainage, but most often it will be a percutaneous drainage. When the wall is not well formed, I think a percutaneous drainage is the safest option. Endoscopic therapy will be associated with a very high risk of perforation when you don't have a good wall. So percutaneous drainage has a place when the patient is not doing well and it's clinically deteriorating.
Okay, good. So the message is, even in 3rd week of illness or 4th week of illness, if patient is not improving, there is a case for percutaneous drainage in such patients. Praveer, would you venture to do endoscopic drainage in some of these patients even before 4 weeks?
Yeah, so I think I had shown that particular study published recently. So I think what is very important in that study also, predominantly they did CT to pick up the wall, whether the wall was well formed or not. So in majority of these patients, they had at least partial wall was there. So that was when they went ahead and did an endoscopic drainage. So I think if percutaneous drainage can be done safely, I think that should be preferred in 3rd or 4th week till we further have more evidence for that. And endoscopic drainage, in for some reason percutaneous drainage cannot be done, that may be the only reason, and the patient is deteriorating, when you want to try an endoscopic drainage.
So that means there are some patients in whom CT actually shows a well localized walled-off collection. You can do endoscopic drainage as well. So you have covered already a question about plastic or metal. In general, plastic is okay, but some patients with large debris, you require a metal, particularly those who have infected necrosis. Another question is about transpapillary stenting and ERCP. So, earlier people used to do this ERCP in every patient and see if there is a leak or not. So nowadays the trend has shifted, because in majority of patients, you can't really bridge the gap, and only showing that there is a leakage or a ductal disruption doesn't really help. And also the data which is coming in now, that DPDS, although commonly seen, doesn't cause much of a clinical problem. So would you recommend ERCP in all patients or no? We generally don't do in any patient ERCP.
So we also don't do.
Okay.
Yeah.
So the short message is, there is no role for ERCP in most patients who are undergoing EUS guided drainage. So another question for you, which has just come in, is there a limit to amount of necrotic debris before you decide endoscopic drainage? 30%, 50%, more than 50%?
Yeah, so I think if the necrotic debris is possibly more than 50 to 60%, I think the patient may be better served with surgical drainage rather than an endoscopic.
So, okay, I think this is one area we are going to have a lot of discussion with our surgeons, and this is a very, very important topic in patients with infected necrosis, whether we go in for endoscopic, percutaneous, or direct surgery. There is a question about direct versus step up. I think this is something we will cover during surgical talks. And one question was to Dr. Shyam Kumar: is there a role for drainage of sterile collections to to improve patient's condition? Any role for drainage
Yes, sir.
of sterile
It is
collection?
done only if it is causing any obstructive symptoms.
Okay.
Otherwise,
So,
there is no role.
there is no
It
role.
doesn't
Okay.
depend on the size of the collection.
Okay.
Thank you.
Although there is a Chinese study which has shown that if you drain sterile collections, it might improve the systemic inflammation. But I think we really need more data on that part. So I think I'm done with most of the questions here, and I hand over the mic to Sudipta. Would you like to continue? Like to have a break? We are already running late. So Sudipta, if you could just come on and take over from here.
For this wonderful discussion that we had, but we are running a bit late, and I would like to request Professor Sahni to take over from here, because I think the discussion should have a very nice transition from the endoscopy per acuteness onto the surgical groups. And I request Professor Sahni to take over from here. Over to Professor Sahni.
Thank you, Sudipta. I think people were looking forward to a coffee break, which you've deprived them of, even if it was sitting at home making their own coffee. While my video was off, I've had the privilege of having my hot soup. So I'm sorry if I have not allowed anybody else to have it. I thought everybody else would get a chance, and I would get a chance to walk around the house. Anyway, we'll move on, and we have two distinguished speakers with us. One is Professor Rajesh Gupta, and the other is Dr. G.V. Rao from two different parts of the country, and they're going to talk about surgical interventions. Let me tell you that I'm not going to give an inch to you endoscopists. Whether you like it or not, I think you people are doing a lot of troublemaking for a lot of us. So Rajesh, would you like to start off?
Yes, sir. Ready.
I'm sure nobody wants me to introduce Rajesh as so-and-so, but he's professor and head of Department of Surgical Gastroenterology at PGI Chandigarh. You've seen his papers. If you have any interest in pancreas, you've seen his papers on acute pancreatitis, and you know of the work that he's done. Rajesh, go ahead. I don't want to take people's time away from you. Go ahead. Thank you.
Thank you, sir.
Rajesh, you can share your screen if you.
Yeah, that's what I'm doing. I think I have to go to system. Just a minute, I think.
Yeah, sure. No problem.
Maybe I have to quit and log in again.
Okay, don't worry. Do that.
If that's an Apple system, that's what you'll have to do.
Yes, sir. I have to actually go to system preference, allow Zoom to have access.
Yeah, access. Yeah, that's an issue with the Apple systems. They require you to do that.
So in the meanwhile, can we have a little bit of discussion on some of these issues?
Yeah, you've got some more questions coming up on the chat.
So one of the questions was that in patients who have got intra-abdominal hypertension, do we do percutaneous drainage or not? And I think the simple answer is yes. If you have patients with intra-abdominal hypertension and the collection, it should be drained. So that is okay. Second is there do we do CT angio over CCT in patients suspected to have pseudoaneurysm? Obviously, if you have a patient in whom you suspect hemorrhage, then you should do CT angio rather than a plain CT or a contrast CT. So this is important. Another question is there a contraindication for a step-up approach? So I think we will take up this question after the surgical talks. This is what I think they are going to cover. Dr. Sahni, would you like to make any comment with regard to this?
Sorry, with regard to?
the issue of step up, I think we should take it up after the.
Yes, I
surgical
think
talk.
so. I think it will be better. It will be because Rajesh and GV are both going to cover some of those issues. So I think it will be better.
Right.
To take it up.
Right. Another question was risk of hemorrhage in metal stent placement. And I think the simple answer is that multiple studies have now shown that if you place the stent and keep it longer than 2 to 3 weeks, there are chances of hemorrhage. And generally it is advised that you take out stent after 2 or 3 weeks. We generally take it out after 2 weeks and lavage the cavity. And if there's significant cavity size there, we replace it with a percutaneous stent. So I think Rajesh is now all set. And over to you, Rajesh.
Thank you, sir, and thank you for the patience. The brief for me is to speak on surgical intervention beyond 2 weeks in acute pancreatitis. So we have moved away from the knee-jerk reaction of necrosectomy when a diagnosis of pancreatic necrosis was made to today when we need necrosectomy in probably 1/3 to 60% of these patients. All the published guidelines today say that recommend that all invasive intervention should be made as long as it is possible, and if it is feasible, probably up to 4 weeks. But what to do, when there is a clear evidence of infection and clinical deterioration before 4 weeks, this has been discussed. So therefore, there is a clear indication for intervention before 4 weeks if there is evidence of clinical deterioration. Let me say here that if we look at the infected pancreatic necrosis, 1/4 of these patients would manifest before 4 weeks. So these are the patients we'll have to deal before 4 weeks. Why is this 4 weeks period so sacrosanct for surgeons? Because the wall of the necrotic cavity may not be mature at when it is before 4 weeks compared to later times. Also, the demarcation between viable and non-viable necrotic tissues is indistinct. Therefore, the force required to remove necrotic material is generally more, and there is loss of the surrounding viable tissue. Compared to when we are doing necrosectomy in patients beyond 4 weeks, where the necrosome actually comes out effortlessly as a cost. Also, the vascular tissue before 4 weeks is immature, and thus there is significantly more bleeding from the wall of the cavity compared to when we operate after 4 weeks. And also one has to understand here that whenever we are operating in patients less than 4 weeks, the primary intervention, the reason for intervention is infected necrosis and clinical deterioration, compared to when we are operating after 4 weeks, when we are, besides infection, persistent unwellness, which may be due to the simmering sepsis and gastric outlet obstruction or bowel complications. What are the choices as surgeons we have? There is a whole gamut. We can do start with an open necrosectomy, which is primary or secondary. Secondary would mean secondary open necrosectomy is after initial drainage. Then we have a left flank approach, and the same can, or a laparoscopic approach. The left flank approach can also be replicated using minimal invasive or minimal access retroperitoneal approach. Then there is minimal incision necrosectomy, and now new kid on the block is transgastric necrosectomy, which can be done both open as well as laparoscopy. However, we have to see which is a patient who will be requiring which particular patient, and the optimal approach would depend not only on the location of necrosis, rather than on the invasiveness of the intervention modality. So if there is a situation or a scenario where a patient does require open necrosectomy, we cannot think of lesser invasive like endoscopic or laparoscopic or video assisted approaches. Having said that, we do have evidence to say that minimal access procedures are the procedure of choice if it is feasible to employ them. That is because they are attended with reduced overall and as well as operation specific complication rate. And when you compare these minimal access procedures with open necrosectomy, it has been shown that there is reduced post-operative new onset organ failure as well as multi-organ failure, along with they are attended with lower Apache 2 scores. Thus, it would mean that open necrosectomy is leading to detrimental effect on organ function. However, minimal access approach would not be possible in around 30% of these cases. So having said that, the open necrosectomy has a role in our clinical or surgical management, but the problem is that to approach a problem which is actually dealt locally, we have to do large dissection with maximal visceral mobilization, and then we reach to the source of the problem. However, now we have known that open necrosectomy following drainage is attended with lower mortality than compared to primary open necrosectomy. And that may primarily be because primary open necrosectomy would be done earlier in the timeline. So therefore that would be the reason. However, the recent study from Japan has shown that invasiveness of the intervention is not associated with mortality. And that is a very clear message I want to convey here. It is the severity of the disease and the age of the patient which was determining the mortality in this series of around 2,000 patients in Japan. So when I come to open necrosectomy, the reasonable option would be a patient where we have extensive necrosis, which is extending along the small bowel mesentery. The general principle of open necrosectomy would be exposure of the necrotic area by transection of the gastrocolic or duodenocolic ligament. Also, if it is possible that the necrosome is peeping through the transverse mesocolon, then that approach can be used through the space of Ryler, but making sure that we do not damage the surrounding middle colic vessels. And the advantage of open necrosectomy is that the whole cast can come out. This is a one-time procedure with 100% clearance, but I must admit it is attended with 34 to 95% morbidity, and that is essentially pancreaticocutaneous fistula. Also, there is a bowel fistula which contribute to this morbidity, bleeding, and in the long term, the exocrine endocrine insufficiency as well as incisional hernias. Mortality is variable. If we look at different series, it varies from 6 to 53%. Our own mortality has been around 40%. It depends on the cohort which one is analyzing, the local expertise, as well as the severity of the disease. Coming to lesser invasive approaches, the one such approach which has been used traditionally since the time necrosectomy was started was a flank approach or a lateral or a lumbotomy approach, where the necrosis in the tail of the pancreas, which is pointing toward the surface around the perinephric area, is dealt with by a retroperitoneal or extraperitoneal flank incision. So the same can also be attended by minimal access retroperitoneal necrosectomy. And this I am illustrating with a patient who had a 2-week illness initially, where there was hypoperfusion of the pancreas, which coalesced over time, which was managed at that time with percutaneous catheter drainage. But subsequently, the patient in the 7th week did not show any improvement, actually was now showing clinical deterioration, and we took up for Ward procedure. And we used the same pigtail catheter tract, dilated it with dilator, and then we used after we started dilating it, we used the Visiport to enter the cavity. And then we starting doing debridement. Important point here is, I think if we are differentiating or looking from the endoscopic point of view, we can look at the size of the chunk which can be removed or is possible to be removed, the kind of vision, direct vision we have. But it is important that we do not become over-aggressive in this. We use small chunks because both the splenic artery, splenic vein, even the common hepatic artery is in the vicinity. So one has to be careful when using this approach. But this can be, in most of the cases, a one-time approach of complete debridement. So then is the minimal incision necrosectomy, which can be used as a standalone approach, or it can be used as adjunct to minimal access approach when the collection is on the opposite side, as is demonstrated in this patient who's 42-year-old male, who had initial treatment with percutaneous catheter, as is the routine here, but did not show improvement. And then the left-sided ward was performed in this patient in 8th week. but then he developed collection on the right side, which was tracking from the head of the pancreas. And this patient was subsequently treated by minimal access necrosectomy when incision was made around the percutaneous placed catheter on the right side in the hypochondrium as well as in the pelvis. And then both the cavities were combined and irrigated till the return was clear. The last approach that I'm going to discuss now is transgastric necrosectomy, which is a new kid on the block. We have actually underutilized this. We have utilized this for pseudocyst drainage, but not for infected pancreatic necrosectomy. This is a one-stage surgical option and has been popularized by a group from Calgary, Indianapolis, and from the west coast of USA. And they have published a large series of around 178 patients. And they showed that it would lead to complete pancreatic debridement and would limit the pancreatico-cutaneous fistula. However, one has to ensure that there is good opposition between the walled off cavity and the posterior cavity wall. And if it is safe, a concurrent cholecystectomy for biliary etiology can be taken up. This is one such patient which we took up where there was extensive necrosis but was localized in the lesser sac. And this is initial phase in the 2 weeks where there was no definite wall seen. We allowed the wall to form, and then by open up transgastric approach, this is an open approach where the anterior and posterior wall of the stomach was open, the necrosum was removed, and the procedure was completed. The same can also be done by transgastric laparoscopic approach. This is another patient which we did before we had the COVID situation. And you can see this is providing a large ostium in the posterior wall of the stomach where a large necrosum can be easily removed. And one can see the inside of the cavity, which is clean. So my take home message is that there is no single procedure which optimally applies to all patients. The procedure has to be tailored to individual physiology as well as the necrosum anatomy. Minimal access approach is preferred modality and should always be used initially if it is feasible. However, open necrosectomy is more suitable for central extension and complications like colonic necrosis and uncontrolled bleeding by intervention radiology. Transgastric necrosectomy is one-time procedure in a subset of patients, which also takes care of the pleurocutaneous fistula by internal drainage, as well as taking care of the etiology in biliary pancreatitis. Thank you.
Thank you, Rajesh. Without any further ado, we go ahead and request Dr. G.V. Rao to talk to us about a direct or a step-up approach, and we'll have questions after both the talks are done. Thank you. G.V., please go ahead.
Thank you, the entire faculty and the executive of Indian Pancreas Club. Actually, this is going to be more controversial and more debatable topic, and I just modified my presentation based on what Dr. Pramod Garg has asked me to talk on. Now, if you look at the evolution of infected pancreatic necrosis, I think all of us know that the basic principles and all the protocols that we follow are basically based on the data that we got from surgery over the decades. Delaying, draining, debriding, deviating from it cause obviously mortality in these patients. So minimally invasive procedures started, invasive radiology, endoscopy, and laparoscopy started, but we seem to be forgetting that the decreased morbidity and mortality is not only because of surgery or minimally invasive procedures, it is because of critical care and ERAS protocols, which have also got inculcated into the entire process. And we have adequate data to show that these are also responsible for the decreased morbidity and mortality that we see. And we keep thumping arches that we're doing the procedure most of the time. Now, there are several issues as far as infected pancreatic necrosis is concerned. Qualification, quantification of this debris or necrosum, the site and extension, selection of this series can be done, is equal to should be done, the functional status of the patient as available, and of course the financial status. Let us look at some of the issues. Now, this gentleman, Todd Barron, created WAN. Is an endoscopic definition. Fluid is pseudocyst, debris is WAN. So if you see this, there is a differentiation between debris and WAN. And whenever you see WAN, it's a combination of debris and necrosum. Now, this is what is called as debris. This is what is called as necrosum. For all the endoscopies, the difference is like between talking about biliary sludge and a CBD stone. I think this is the difference between a debris and a necrosum. Now, in 2020, the endoscopic interventions are, most of the radiological interventions are based on endoscopic ultrasound and an MRI, and US is very sensitive, and the conversion rate of CT pseudocyst to endosoma WANs is very, very high. And if most of the WANs in endotherapy series or even in the interventional radiology series are, in fact, CT pseudocysts. Now, this is very, very important. Majority of the WANs just need simple drainage. Debridement is required in minority of the patients. I'll tell you why. There is a beautiful study just now the endoscopists have said, because plastic versus metal stent, because there is ambiguity in that, just because majority of the patients just require drainage and they don't require debridement. I think it's very, very clear. Majority require just simple drainage. Now, as regards the site and extension, you have this classical walled-off pancreatic necrosis. This is agreed in approximation to the stomach and duodenum. And what we call these extensions into paracolic gutters, mesentery, pelvis, or into the mediastinum. Now, these are called as extended walled-off pancreatic necrosis. So there is difference between walled-off pancreatic necrosis and extended walled-off pancreatic necrosis. Now, this step-up approach, which came in 2010, seems to have been the game changer, and everybody switched on to this procedure. And we have data, a small data, which came in to show that the step-up approach is very, very good. And we have the long-term follow-up to show that this is good in select group of patients. But if you critically analyze this patient, I think you should know that what this paper has raised is two issues. One is the extent of pancreatic necrosis. They classified less than 30%, 30 to 50%, and more than 50%. I'm not very sure. Pramod should answer how to quantify this. And also, what is this laid down is the access route to these pancreatic necrosis. These two are the most important things whenever we're treating this infected pancreatic necrosis. Now, if you see our own data from our own center, a step-up approach used for walled-off pancreatic necrosis, 75% of the patient required just simple drainage. They did not require any debridement, please. 75% just put in a stent, leave the patient, they're all right. But they're all walled-off necrosis. And then we have stent declogging done another 10%. This is less than 10% of the patient requiring some sort of endoscopic direct necrosectomy. So majority of the patients, majority of the WANs detected in clinical practice just require clinical drainage. And this is also the data which comes true from patients who are doing drainage percutaneously. I have a lot of data to show that. Now, when it comes to direct surgery, you're talking about, it is either open surgery or minimally invasive surgery, which could be laparoscopy or retroperitoneoscopy. The direct debridement is what is the conventional method. It can be done either by using a trocar, a standard method, or a trocar, a Sills port, or a TEM port, and it can be done in critically ill patients and all these patients which is extending into the paracolic area. So this is the conventional ward wherein we do the debridement as shown earlier by Rajesh, and we put in 2 drains to irrigate. And this is using a trocar, a VisiPort. Actually, you can see this. We are putting a direct big trocar directly. We mark this, and then we introduce into the walled-off necrosis. And then this is a bigger port as compared to the interventional radiology drain, which is about 10 to 16 French. And under vision, you can see these rigid instruments can be passed, and you can see this big vessels traversing the retroperitoneum. This can be avoided, and you can do a clear debridement of all this. And then subsequently, at the end of the procedure, you can put 2 drains which can be left alone for irrigation, and then these patients do extremely well. The same thing can be done using a single port wherein you can pass multiple accessories to this so that the debridement part becomes easier. Or you can even use a TEM port like we have used it here. This is a transanal endoscopic microsurgery port which can allow passing of multiple rigid instruments. Here we have been using the same port here, and you can see that ease is absolutely fantastic. And then we can get good vision because of the rigid scopes, and also because of the rigid instruments which are available. We should be able to do a good debridement and complete cleansing the entire retroperitoneum, and then a lavage, and then subsequently train these patients. And you can see these patients are absolutely very comfortable because we are not getting into the peritoneal cavity. and they do very well. Now, there is a lot of data to show that these patients do very well and the mortality is very, very low. You can see this, the mortality is less than 5% in majority of the series. Now, laparoscopically, again, we can do transgastric, retrogastric, retrocolic, retroperitoneal approach. All these are accessible. All potential areas can be accessed. Complete removal is possible, as shown by Rajesh, and it can be augmented by use of a hand port. And if you see the data coming in from all the things, the success rates are very, very good. Now, this is one beautiful paper which comes from our own country to show that all these procedures can be practiced with minimal complications as compared to what endoscopists or interventional radiologists keep talking about. So all these accesses are possible with minimal morbidity and mortality. Now, the biggest thing that came in was this paper from the All India Institute group, which has shown peripancreatic fluid or walled-off pancreatic necrosis, less than 30%. Yeah, this 30%, again, this is very, very important. Now, both endoscopy and laparoscopic drainage seems to be absolutely similar. So we cannot say that they're different. Both endoscopy and laparoscopy are similar. And obviously, if it is more than 30% or 50%, they require some sort of laparoscopic or surgical drainage. Surgery is done predominantly by the post-continuous lavage. And again, you can see this, if you see the mortality coming in from different series as recently, the mortality is not 40% or 50% as what people talk about. Majority of the series, it's about 10 to 15% mortality. You can see all this data which is coming up shows the mortality is very, very low as compared to what the interventional radiologists and the endoscopists keep talking about. Now, is open necrosectomy obsolete in current day clinical practice, or is it still useful? You can see this. It says that it is very useful, and the mortality rate of necrosectomy after 20 days is about 11%, and more than 50% mortality if multiple risk factors are present, but there are no mortality if no risk factors are associated in these patients. So open necrosectomy is very, very safe, and the mortality now is not 40%, please. It is just around 10%. And this is, again, a beautiful paper to compare surgical transgastric necrosectomy. And here you can see this, we are comparing surgical transgastric, open surgical transgastric necrosectomy, which is a single stage procedure, which is absolutely very, very good for these patients. Now, this is, again, open necrosectomy people believe is obsolete, but again, this is a beautiful paper that comes from Gangaram Hospital, which shows that still open necrosectomy is being practiced in an emergency procedure in majority of these patients coming for pancreatic necrosectomy. And again, this is a beautiful multi-sector study. I mean, all the endoscopies, the big guns in endoscopy, big guns in radiology, big guns in surgery are involved in this. This is what was published, which is the practice guidelines in 51 hospitals across 8 countries, including 1980 patients. And you can see this predominantly, even open necrosectomy still continues to play a big role. Surgery comes next and endoscopy comes last. Please, let us, open necrosectomy still is a big player in current day clinical practice. And even in our own country, if you have to go to some peripheral place, other than these tertiary referral centers, I think open necrosectomy still has a big role to salvage these patients. Again, one can be done is not should be done. Please. This is one patient, even before maturation, you put in multiple stents and the stent get into the peritoneal cavity. Obviously, neoperitoneum, this patient obviously has to be converted to open procedure and then debridement done. Again, this is one such patient. Again, you can see the collections are coming anterior to the stomach. And then they go and put in 2 stents into this anterior collection, anterior stomach. Obviously, this patient is not going to do well and then requires some sort of surgical intervention, open debridement. Again, expertise is what is required. Actually, if you cannot debride the stent properly, this is what happens. You get the stent into the peritoneal cavity, and obviously this requires some sort of open drainage, because once the cyst get decompressed, it is very, very difficult to get into this walled-off necrosis laparoscopically, because we cannot identify this walled-off necrosis. And again, this is one such patient with a colonic perforation and interventional radiology procedure done. This patient obviously has got a huge colonic communication here, requires some sort of colon resection and an ileostomy and a drainage, and subsequently we salvage these patients. Again, this is one such procedure which in an endoscopic stent was put, massive bleed from the stent side, and then we have to open this patient. You can see this huge clot And you can see this sort of a bleed from the splenic vein. It is bleeding here. There is no endoscopic procedure or radiological procedure that can control this sort of bleed here. You can see this. There's a huge splenic vein that is bleeding in this patient. Open and then salvage this patient. So if you see all the quoted comparative trials, there is bias selection criteria. See, if you see all the endoscopy series, they have people which have beautifully walled off necrosis in approximation to the stomach or duodenum. And IR, even the Panther trial, 90% of the walled off necrosis had good access for interventional radiological procedure. So all the trials seem to have some selection bias, and then you're selecting these patients so that you're opting for these procedures. So we had this problem actually, I mean, we all know we have good endoscopic expertise, good radiological expertise in this. So initially all these patients used to go for interventional radiology or endoscopy procedure. Subsequently, we decided that this is not going to help because it has to be chosen based on the patient. So we had started having this for all patients with wall of necrosis who are going to require some sort of intervention. And you can see this, our own data when Panther started, our open necrosectomies or surgical interventions were very, very less. But subsequently with this tumor with pancreas board coming in, the number of interventions, surgical interventions started increasing. The primary surgery started increasing. I mean, though we have this procedures also increasing, and if you can see our own data, we can see this. If patients undergo primary surgery, the mortality is very, very low as compared to patients who come after PCD or endoscopic drainage, where the mortality is very high, basically because of some infected or nutritional complications in these patients. So I personally believe if we have a walled off pancreatic necrosis in approximation to the stomach or duodenum, less than 30% debris, you go for endoscopic drainage. If it fails, it doesn't fail, maybe surgical intervention. More than 30% debris, these patients could require an open and laparoscopic procedure. Beyond the stomach and duodenum, that is the extended wall of pancreatic necrosis, less than 30% debris, interventional radiology procedure, or an open lap or ward procedures can be done. If it is more than 30% debris, unstable patient, IR step-up approach, and if fails, open surgery. Stable patient, interventional radiology step-up approach, if fails, open surgery. And if it's a stable patient, laparoscopy, ward, or an open surgical procedure can be done. Any of these patients with complicated wall of necrosis in the form of enteric communication or bleed, I think these are the patients who would require some sort of surgical intervention. This paper from Sham is very, very clear. Now you can see this wall of pancreatic necrosis, which is like a ripe mango, which is in good approximation to the stomach or duodenum. These are the patients who do extremely well. If there's less than 30%, they do extremely well with endoscopy. But as the wall of necrosis becomes extended and goes beyond the stomach and duodenum, I think we have surgical intervention, maybe minimally invasive or open surgical procedures would be very, very helpful. And I'm sure that this has been taken up initially. Actually, we talk about pancreatic necrosis. We postpone the drainage by Panther. Now we're talking about immediate drainage. Basically, again, the interventional radiologists want to come into the picture to show that minimally invasive procedure or percutaneous drainage is superior. But I'm not sure how this trial is going to come through. We just have to wait for the data. So to conclude, the management concepts of walled off necrosis evolved and standardized from conventional surgery. Minimally invasive techniques are becoming popular with decreasing morbidity. Surgery continues to be standard of care because of several limitations of minimally invasive techniques and compliance issues. Primary surgery, including laparoscopy, retroperitoneoscopy, are associated with good outcomes with low morbidity and mortality. And whenever we have endoscopy or IR failures, they require open surgery because localization and complete necrosectomy by laparoscopy is difficult. They're associated with increased morbidity and mortality because of septic and nutritional factors. So basically, I personally believe that it's part of a multidisciplinary approach, HPP surgeon, endoscopic and interventional radiologists, but tailored to anatomical location, comorbidities, and available expertise. But we should not forget the critical care intensivist who seems to be playing a big role in the management of these patients. And I go with you to read this paper, which says there are many different interventions in varying states of evolution are available for the treatment of pancreatic and peripancreatic necrosis. these interventions should be offered in the context of optimal intensive care and medical management, and that a multidisciplinary approach is required in the center with specialized expertise. Thank you so much once again for the patient here.
Thank you, GV. That was, you batted very well for us. I have no issues with you. Maybe we should just ask Pramod to come in and try and defend himself. So I think one of the most important things that you've brought up is the issue of suitability of a procedure for a particular patient. And I think that's extremely important in patients with acute pancreatitis. You could have a patient who could do very well with an IR procedure. There could be a patient who could do very well with an endoscopic procedure. And there could be a patient who could do very well with the surgical procedure. And if I were to do a trial, a randomized trial, I could very easily put an inclusion-exclusion criteria where I exclude patients whom I do not wish to include into the study.
Yeah, absolutely.
I then have 70% patient population whom I've excluded. Therefore, the generalizability of my study becomes limited to a certain subgroup of patients. However, people who read the study read just the abstract or just the title of the paper and say, okay, very good, this is something that I wish to do. And I think what you've brought out and what Rajesh has also shown is that the issue here is to be able to individualize a patient, look at the patient carefully, look at the images available carefully, look at the clinical course carefully, and then sit down, everybody sits down, has a discussion and decides what to do. It's an MDT approach which might be useful. Very quickly, I just want to say that I personally believe that while the intensivists have done a great job, a fantastic job, it doesn't necessarily mean that the improvement in survival that's happened has happened because of them alone. Yes. I think it's also because we've understood the disease much better. We've got this 4-week time frame. I'm not sure whether 4-week is, 27th day is not good and 28th day is good. So that's something that we all need to remember. There could be a patient who could benefit at day 21, and we should be willing to benefit that patient or provide that patient that benefit on day 21 and not wait unnecessarily till day 28. On the other hand, at day 28, it's not necessary that we must intervene. There could be a patient in whom we could benefit the patient a little later or may not need to do anything at all. So after these sort of brief comments, I'm happy to let Pramod say he wishes to make a remark before we take some of the questions that have come in onto the chat box.
Thank you, Professor Sani, and thank you both Rajesh and Dr. G.V. Rao for these excellent presentations. So, I mean, if I'm an endoscopist, I will say I will do the best job. Radiologist will say he will do the best job. The problem comes in patients in whom the presentation and the morphology are not so clear cut. So if I have a patient with a lesser sac collection, even if the debris is 50%, very nicely localized and walled off, I can easily do an endoscopic guided drainage and put a metal stent, no problem, even if it is infected. Although majority of such patients are those who have sterile walled off necrosis. The problem comes in a patient is the 3rd week or 4th week, collection is in the lesser sac, extending to paracolic gutters, either on one side or both the sides. It is not very well walled off. Patient is sick, he is septic, he has just recovered from organ dysfunction, has either still in the ICU or coming out of the ICU. Now is the time when we have to decide whether you go in with a percutaneous drainage and then upscale to necrosectomy, which could be either open or ward, or we directly go for surgery. And I think, as you have very rightly, GV, shown that the PENTER trial was limited to patients who had very well localized collections. Most 40% had less than 30% debris. and 70% had less than 50% debris, then it is okay, no problem. But in other situations, is step up always indicated? That's the main question here. What are the indications? What are the situations where you will say, I will not advise you step up, I will say, go ahead and do direct surgery? Because problem is that what happens, you linger on for weeks together. So we start one antibiotic, surgeon will come, no, you add another one. We drain one, they say upsize the catheter, then say there is another CT, another collection, put another drain, and 3 to 4 weeks easily pass off. The albumin goes down. Even if you give 1000 to 1500 calories, it is not enough. Patients become malnourished. He is septic. He has already received 6 or 7 antibiotics over a period of 6 weeks to 8 weeks. So that is a situation where I think surgical outcomes are not good. What Rajesh was saying, your mortality is 40%. This is, I think, because of the fact that we have lingered on for long, and patient is malnourished, albumin is down, and there are MDR infections. So I would request both of you to say, and all three of you to say, when is the time you say no more prolonging the treatment, go ahead and do surgery?
Yeah, Rajesh, go ahead.
Sir, if I have a patient, like you said, a patient where the necrosum is in the lesser sac, patient is sick, but is in the 3rd week, maybe in the 4th week. But it is not important, as I think Professor Sani was alluding to 27th or 28th day. These patients may have a wall of necrosis or a wall which is visible even in the 3rd week also. We have seen patients 21 or 22 days with wall. So in a patient like this, I would rather go in as with a transgastric necrosectomy as my favored approach. It can be laparoscopic or open depending upon the patient's condition. If patient cannot withstand this or laparoscopic, then I would go ahead and make a small epigastric incision, open the stomach, open the posterior wall, do the one-time debridement, which also takes care of the internal fistulization, internal drainage of the pancreatic fistula. So these are the patients where I think we should not linger on, give one antibiotic, second antibiotic, try to postpone beyond 4 weeks, and then allow surgeons to go in when they are already been nutritionally depleted, they are in organ failure, and they are immune suppressed. So these are the patients where the surgical outcomes will also be compromised.
I think we can go ahead with a number of different kinds of scenarios and try and discuss those scenarios. But let's take a few questions on the, and we must remember that we have sort of run out of time also. We have a panel discussion, so let's quickly run through some of the questions that have come in. Nalini Kanta is asking objectivity of clinical deterioration. How do you objectively decide that this is clinical deterioration? And how long would you wait? So how long will you wait? We've just said, 28 days is not sort of sacrosanct. It could be less, it could be more. But objectivity of clinical deterioration. Any one of you would like to comment on that?
I think because the medical people should comment on this actually. When do you want to refer this patient to surgery?
So I think first of all, there is no fixed criteria how long we should wait. The clinical parameters that we look at is obviously fever, leukocytosis, and improvement in organ dysfunction score. So that is important. So if I find that the organ function is deteriorating, even by score 1, with my, say, for example, 1 week of antibiotics, we will go in. Either we do percutaneous drainage or we do something else. So I think 3 to 7 days is a reasonable time frame when you say my antibiotics are not going to work. And this variability will always be there. Nobody can say 3 days, 5 days, or 7 days, right? Once I decide it is not working, we have to intervene, we then go in. And same parameters will tell me even percutaneous drainage is not working. So I think 5 to 7 days is a reasonable time frame when you can say the current strategy is not working, we have to move to the next.
Okay, so one more quick question. And is there a minimal amount that you must debride if you're going in? Whether you go in endoscopically, whether you go in through an interventional route or you go in through a surgical route, The surgeon would obviously want to attempt to remove the maximal amount because he or she doesn't want to go in again, subject the patient to a major stress like surgery all over again. But for the endoscopist or the interventionist, is there a minimal amount that you have to remove? So say I've got 50% necrosis. Would you try and remove at least 50% of the 50%? Or would you try and be happy with 10% or sort of, if you don't have a complication, if you have a patient who's stable, would you go ahead and continue to remove till you are able to remove all, or would you attempt to remove only a certain percentage?
I think you're talking about endoscopic drainage, no? I think
endoscopic interventional surgeon. So for a surgeon, I personally think, but from you and Rajesh, you'd obviously want to take out the maximum.
Yeah, whatever is the loose tissue which can come out.
All the loose tissue that can come out. So, Pramod, would you?
So generally, our approach in endoscopic is to take out the loose debris. So as G was saying, we only drain initially. Drain and lavage. To my mind, these are the best things. Once we find that patient is still having signs of sepsis, we go in and take out the loose debris. So we should also understand that taking out the entire necrotic debris is really not required. The reason being, in patients with sterile necrosis, they get better without any intervention. The body takes care of the debris. So whatever loose necrotic debris is there, we should try and take out if there is no improvement after drainage. Not all necrotic debris needs to be taken out.
So we have another question which says bleeding after necrosectomy, what is its incidence and how to prevent it? So I presume bleeding occurring after any intervention, endoscopic, percutaneous or surgical intervention. So incidence and how to prevent it. Rajesh, would you like to take this?
Sir, I think
surgically?
After we have looked at the incidence of bleeding after percutaneous drainage, and in our series, what we found was it was varying from 9 to 11%. The question here was how to prevent bleeding while doing surgery. I think I partly covered it in my talk that we should not remove those tissues or necrosum areas which are coming with difficulty. So anything which comes easily and effortlessly is the only thing which should be removed. Anything which is requiring force should be left, considering that to be a vessel. That is probably the best way to avoid this. If it has occurred, then if it is from a diffuse ooze from the cavity, then only thing one has to do is just pack the cavity, do nothing more at that time. But if it is occurring from a vessel which is arterial, then one has to tackle it. Then there is no question. You cannot wait on a bleeding artery.
Okay, I think we'll just have to stop here because we still have a panel discussion which has to happen, and we're far past our time. So thank you very much, Rajesh and GV, and to the Indian Pancreas Club, and to everybody else who's, including Sudipto, who's been very persistent in getting us all together. Thank you so much.
Thank you, sir.
Thank you, sir. Over to Sudipto now.
Thank you, sir. Thank you, everybody. And thank you, sir. So we've had two webinars on acute pancreatitis, which we have attempted to cover the most important topics related to the management of acute pancreatitis. Now we move on to the panel discussion, in which we hope to summarize the discussions we've had so far on acute pancreatitis management. I would like to request Dr. Ajay Kumar to kindly take over from here. Thank you, Dr. Ajay Kumar.
Dr. Ajay Kumar is a very senior gastroenterologist consultant in New Delhi and has been interested in pancreatic diseases for a long time. And he has very kindly agreed to moderate this session. Dr. Ajay Kumar, please.
Can you see my screen?
Yes.
Okay. Well, friends, running short of time. So we had a very exciting and a very interesting talks on the management of acute pancreatitis second week onwards. And if you look at it, the whole of discussion was focused on how to manage the peripancreatic fluid collections, which is a challenge for all of us. I have a distinguished panel of panelists here. Dr. Janta from PGI, most of them are known to all. Soumya from All India Institute, all young people full of enthusiasm for pancreas. Sandeep Paul from Calcutta, and Dr. Manba is a surgeon from CMC Vellore. See, what we've done is briefly that try to just put all the things together, what has been discussed, and make a very easy thing, the carry home messages. If we can, we hope we are able to convey that. Well, issues in second week, which is rightly pointed out in the first talk by Dr. Pranam, there is a organ failure, infection, nutrition, and fluid collections. And so further on, today we are focusing this panel discussion only on one part of it, which is the most important, on fluid collections. This slide has been shown multiple times during the last 4 or 5 presentations, so I don't need to go into that again. Now, we also have seen this, that all these conditions, we have 4 different approaches, and how do we bring them together, as nicely brought out by G.V. Rao in the last slide, that you have a teamwork. Actually, there is no fight between this is only on the stage that you're fighting with each other. At clinic, you are basically working as a team, because there is no way other than a teamwork between these specialties, surgeon, radiologist, and the endoscopist, and of course the intensive care is always a part of it. The variable factors when the decision making comes, what is the duration of illness that we have already discussed a lot, whether infection is present or not, approximation to the stomach and duodenum, and amount of debris, all these points have been brought out in great detail in the separate presentations. So what we are talking about now is take one by one the clinical situations. I'm very brief, try to cut down the discussion, and I'll request the panelists also to be brief in their, so that people are carrying the carry home messages. So here we have a 50 years male, 3rd week of acute pancreatitis, has a low-grade fever with a mild leukocytosis, single organ failure. Patient is stable, is not worsening. I've given only this single spot film of a CT scan, which shows that. The question is, Sandeep, will you intervene?
Yeah, in this case, we won't intervene now because it is a 3rd week and patient is relatively stable, and the collection is acute necrotic collection without any definite wall, as I could see in the CT film. So we'll wait on this patient and continue conservative management.
So the carry home message is that most of the sterile collections do not need intervention, and more so in first 4 weeks, as earlier pointed out by a number of speakers, that only time when you interfere with the sterile collections is when they are causing obstructive symptoms. Somebody had asked a question in the chat box that does it improve the SIRS? The answer is we have no evidence till now, except for the one Chinese study which was quoted by Pramod. Other than that, at this stage, I think this is one area we should not rush in the initial stages, especially when there is no clinical evidence of active sepsis. The same sort of a situation a bit later, fever is high, high TLC is around 20,000, organ failure is persistent, and there's not responding to antibiotics given for almost a week or 10 days. Now, what is the next choice? Dr. Soumya, will you intervene? The question is first is, will you intervene? And if you will intervene, this is the 4th week of illness. I will say beginning of 4th week. I'm not putting like Dr. Piyush, he said 26th day, 27th day. Okay, let's put in the beginning of the 4th week.
So in case of worsening sepsis, despite antibiotics, and we presume this sepsis is due to this collection and you don't find any other source such as pneumonitis or any source, then we would like to drain that collection. However, the issue is if you put a catheter in a sterile collection, it will get infected. Suppose a patient has pneumonitis, is having worsening sepsis, and there is a collection, you put a catheter in the collection, you made that sterile collection infected. That's the issue. That's why the trial, pointed trial is going on, along with similar trial regarding drainage in 3rd week or 4th week in case of worsening sepsis, whether it's needed or not. That's an important question. In AIIMS, we are also running a trial where in halfway, and also a similar trial is running in China also. So what is the approach? So in that case, the wall is not well formed. So if the wall is well formed, we can try an endoscopic, but in this case, I would prefer for a percutaneous drainage to a retroperitoneal route.
So I hope all the learned speakers agree at this stage up to what we have pointed out here is a possibly a non-controversial that if you need to intervene in an early stage, then probably we'll start with a percutaneous approach, and then you talk about step-up approach or anything, what is to be done. While we are on this, what is the success rate of percutaneous approach alone without any step-up or any additional thing? And complications, I think we have already discussed about that in the presentation. Can you just tell us that how many percentage of patients only percutaneous approach is good enough?
So there is a meta-analysis in which we have studied only percutaneous approach or percutaneous approach plus necrosectomy in patient with infected pancreatic necrosis. Percutaneous approach only was successful in 60% of patient, and they did not need necrosectomy.
So step-up approach has been discussed in great detail. Would you like to add anything, Soumya, for a clear-cut thing? Clear-cut message?
If a patient after percutaneous drainage is having persistent organ failure, sepsis, sus, we need to do a necrosectomy within after 7 days or 10 days of percutaneous drainage, so that you don't delay much.
So as we said earlier, that indications for intervention in the first 4 weeks of illness are if there is an uncontrolled infection, that it should be changed to uncontrolled infection, or you have an intra-abdominal compartment syndrome. I'm not sure how often we don't see it very often, but yes, once in a while we come across that. And I hope the surgeons are not offended by saying that in the initial stages, surgery is not the option. Of course, we all have talked about the step-up approach when the surgery is, actually when we talk about step-up, we are talking about percutaneous drainage followed by surgery. Dr. Surgeon in the panel, Doctor, will you like to agree with that, or you have some difference of opinion on that?
I would agree with what has been mentioned, sir. I think in this patient, definitely surgery will not have a role right away.
So we come on to the next case scenario. Here is a 45 years old lady, acute pancreatitis, 5 weeks passed, fever, not responding to antibiotics. You have this film, you can see there is a clear collection with some air inside, indication of probably sepsis. It is possibly sepsis. Now, Dr. Chenta and Dr. Manbar, this is where we come on to the controversial areas. Now, we all know that these are the approaches. Dr. Jenta, what will be your thought processes on that? And Dr. Manbar, then do you agree on this thing? I'll leave it to both of you.
I think, sir, I'd like to add that looking at the CT film, we can see that there is a lot of air inside. There is, it is beyond 4 weeks of illness. There is a discernible wall that can be seen. Many of the times, if the patient is just running fever without any organ failure, and with this much amount of air, we would definitely like to rule out two things. One is definitely an gas-forming organism causing this infection, and second could be a GI fistulization, which can lead to this much amount of air as well.
Excellent. So, I'm glad that you raised the issue. But I just clarify that we did that. We did a CT scan, contrast, and rectal contrast, and this thing, and we could not elicit any any visceral communication.
So in this situation, since it is close to the gastric wall with less than 1 centimeter gap between the wall and the collection, the wall has well formed. This is a most likely a walled-off necrosis with infected walled-off necrosis. So I'd like to go ahead with an endoscopic approach for this kind of a collection. The flip side would definitely be the collection looks very large. So in that situation, many times what can happen is that after placing one port, creating one port for the EUS, a multi-gated technique might be required, and later the patient might require a direct endoscopy necrosectomy. So my approach will be endoscopic approach first.
You would like to go for it, endoscopic. Dr. Manbar, do you agree with your colleague, or will you like to differ with this?
Yeah, I think a lot depends on the availability of expertise, and yes, definitely this collection looks like it's mainly fluid and very less debris. I think our endoscopist colleagues would probably do a additional MR just to know how much of necrosis is there. And if it is
next question.
If it is mainly fluid, then endoscopic drain placement, either a plastic stent or preferably a metal stent, because just that it gives us a a bigger, connection between the cyst and the stomach. So yes, endoscopic is a good option for this patient.
So as we talked earlier, the variables in decision making are the duration and the timing of the fluid collection, what we are trying to intervene, in presence of sepsis or no sepsis, and the approximation with the stomach or the duodenum. And we talked about the debris, and that's why this Dr. Manba said that he like to do an MR to check the amount of debris. And and this, I think, has been earlier clarified quite a lot by the Dr. Pankaj from PGI, that MR and US will be the right options. And Pramod clarified that we like to do the MR first to have a better idea about the amount of necrosis before we go ahead with that. And as the panel agrees that this is how we manage that, we put in a Nagi stent and the whole thing collapsed. There's all liquefied, very little debris, and this patient did very well. There could be a difference of opinion that there is an associated infection. Should you go for a more aggressive approach? But if you have such a clear liquid and such a clear approximation, then usually this stent helps. Now, my question is, what is, Dr. Jayanta, what is the success rate of the endoscopic approach? And in a situation, what is your decision? When do you take, is a plastic or a metal? Though Dr. Praveer did talk about that. And can you talk briefly about the step-up endoscopic approach?
So about the success rate of endoscopic approach, multiple meta-analysis has come out actually, basically. So the success rate ranges from 80 to 90%. Nowadays, people are reporting close to 90 or even more than 90% with the LAMS. But for that matter, some meta-analysis, as Dr. Pravira had clearly highlighted, that for walled-off pancreatic necrosis, some meta-analysis reports that probably metal stent has a slightly higher edge over the plastic stent. But per se, otherwise, the other meta-analysis they say where they have compared both the pseudocyst as well as the one combined, they have found that both plastic and metal stent have equal value. So we do not know. There was a recent multi-center study, retrospective study that have come up with more than 300 procedures. And they said probably the metal stent edges over the plastic with the success rate of 80 versus 60%. And step-up endoscopic approach, I think Professor Rao had clearly highlighted that AIG study, which clearly showed that the drainage of one is just the placement of the stent is adequate for more than 3/4 of the cases. In another 9% cases, only 9 to 10% cases, actually a DEN is required. So first to place a metal stent, you declog, you irrigate. That is good enough for around close to 90 to 92% of the cases, and only maybe around 9% cases would require some amount of direct endoscopic necrosectomy. So a step-up endoscopic approach will definitely be warranted in these situations.
Soumya, you can talk about briefly about quickly what are the complications of the metallic stent and how long do you advise today to keep the stent in?
The metal stent would like to keep 2 to 3 weeks. We don't like to keep more than 3 weeks because there are increased adverse events, especially when the cavity is collapsed, the inner flange of the metal stent touches the opposite wall and it can erode the wall and erode the vessels, may cause bleed, and it may, so there is increased adverse events after 3 weeks. So 3 weeks is the best time to remove.
So after we go to that, there's another patient. Patient had 6 weeks history. Patient, the fluid collection, gross sepsis, multiple admissions prior to he came to our place. And this is the picture that we had received multiple antibiotics, still running fever, not an organ failure at this stage. And this is a recent patient that we had last month. And this is where actually the team's decision comes in. And if you look at the MRI showed very high amount of debris. And then we did a contrast CT that did not show any communication with the bowel. And question is, what are the options? Here, I straightway asked my surgical colleague to please have, we had a team-based meeting. We'll just tell you what we did with that. But before that, let's have Dr. Manba's opinion. What will be your approach in this patient? The same we have.
So specifically with biliary pancreatitis, as Dr. Rao had mentioned in his approach, in his speech, patient hemodynamically stable, though running a little bit of fever. As a one-stop option, definitely I would probably think on laparoscopic cholecystectomy with laparoscopic drainage of this collection. However, again, if the MR does not show residual gallstones, then I may still consider an endoscopic drainage for this particular collection. I would not rush towards doing a laparoscopic cholecystectomy and drainage, just for the fact that this collection, again, it looks like mostly it is has minimal debris, and I think just an endoscopic drainage would suffice.
Remember, the debris was more than 60% as seen on the MRI.
Yeah,
we are not getting
then it depends on the expertise. If there is a surgeon who is capable of doing a laparoscopic cystogastrostomy, then definitely as a one-stop approach, laparoscopic cystogastrostomy, drainage, and lap cholecystectomy in the same sitting would be the first choice.
That's exactly what we decided in our team meeting. The surgeon went in, did a lap cystogastrostomy, and also with a separate incident did the necrosectomy because the debris were too much. And this patient had a very uneven full recovery and discharged home on the 7th day. And it has been almost 2 weeks now. And he came for a post-operative visit yesterday. And patient is doing extremely well on a normal diet. And of course, the gallbladder was also removed in the same sitting. So that way it's been very rewarding. So see, we keep on talking about controversies, debates, and all that. But when it comes to an individual patient, when, as earlier pointed out very clearly, it's a teamwork. All of us sit together, discuss all the pros and cons in an open mind. And I think most of the time, we'll make the right decision in the interest of the patient. And of course, this is we talked about the different approaches of surgery. Actually, this is the last case that I'm showing, that this is another patient who had a multiple collections, paracolic, and this thing. There's no way we could think of this any endoscopic approach. The only choices were in the initial phase is the percutaneous, and then surgery, whether open or a minimal invasive. Dr. Manba, what do you comment on that?
Yeah, these collections look very much like collections in the setting of acute, peripancreatic and extended peripancreatic fluid collection. I cannot definitely see any walled off a wall around each collection, and it depends on the patient's hemodynamic status. Definitely, if the patient is hemodynamically unwell, then percutaneous drain placements, multiple drain placements, whichever feasible, as much as possible retroperitoneal. But if retroperitoneal access is not there, then definitely transperitoneal also. We would do that just to get over the sepsis and get back the patient to being hemodynamically stable. And that would be our first approach.
Sandeep, anything that you like to add?
I completely agree with Dr. Manba, because this is a patient who, if he is hemodynamically stable, then I think percutaneous approach will be the first preferred approach in this patient, because there are multiple collections all over, then lot of pancreatic fat standing, and multiple collections in the paracolic gutters also can be seen in this patient. So I think we will percutaneous approach will be the best approach for this patient.
See, this is what we did. We had a step-up approach. We had a percutaneous, and ultimately we went for a necrosectomy. But unfortunately, this is one patient in the whole series that we have shown that we lost. That doesn't reflect on the surgeon. It reflects on the seriousness of the patient, that these patients ultimately require surgery like that. They're ultimately, they are very sick patients, and they need, quite often you can have a bad outcome. So friends, at that point that I want to highlight, that there have been number of approaches discussed, debated, but at the end of it, what everybody said earlier, GV and Piyush and Pramod stress on that, it's a team approach. And I believe me when I say that none of these cases have been discussed with the panelists beforehand. And if you look at this, a decision of everybody comes to the same level. Once you sit down, we all understand what is the right for that particular patient. There could be odd patient where there could be that maybe this is right, maybe this could also be right. But when you take all those variables in mind, most of the time, if you sit with a clear head, then you will be able to take the right decisions. So my take-home message is that please individualize your case selection for each approach. Every approach is good for a particular patient, depending on you to select the right patient. And decision-making has to be a teamwork. And with that, we can definitely improve our patients' outcomes. And with that, I will thank and pass on the mic back to Sudipto and Pramod. Thank you very much.
Thank you.
Thank you, sir.
Thank you so much, sir. It was a wonderful teaching session. I think you have covered almost every aspect of infected necrosis, from complicated and all the complications you've covered wonderfully. And I thank all the panelists, Soumya, Sandeep, Jayant, Manba. Thank you very much for being here. I understand for the want of time, we will just we'll move ahead with the story. I would like to take this opportunity to thank the moderators of the previous session, Professor Saraswat, who's left to attend another webinar, Professor Sahani, and of course the speakers, Prema, Dr. Sham, Dr. Pankaj, Dr. Praveer, who's now moved on to another webinar probably, and Dr. Rajesh, and of course Dr. G.V. Rao. I also thank Soumya once again for being a backbone behind these webinars, because without his help, well, I wouldn't have been able to conduct these webinars. Thank you, Soumya, for being there. Thank you, everybody. We've had around 238 people who have logged in during the course of this webinar and have been continuously there. So thank you, viewers. We look forward to having you for our next webinar, which would be on the 5th of sorry. Yeah, it will be on the 5th of I'm sorry for this. Yeah, 5th of December. And that would be on recurrent acute pancreatitis, autoimmune pancreatitis, and genetics of chronic pancreatitis. Hope to have you all on during the course of that webinar. Thank you once again. With this, we close this session. Thank you very much.
Thank you.
Thanks, sir.
Thanks, Sudipto.
Thank you.
Thank you.
Thank you, sir.